All right, members, will we please go ahead and turn on your cameras and we will get this meeting started. Welcome to the first meeting of the Interim Standing, Joint Interim Standing Committee on Health and Human Services. Members, before we begin, I just want to make sure members and folks participating on the Zoom have your microphones muted. Unless you are speaking, please. This minimizes background noise, but if we can keep our cameras on, that will help us maintain a quorum throughout the meeting. Mr. Ashton, will you please call the roll?
Senator Doniate?
Here.
Senator Hardy?
Here.
Senator Harris?
Here.
Assemblywoman Golo?
Here.
Assemblyman Haven?
Here.
Assemblyman Orndlicker?
Here.
Assemblywoman Titus? Chair Peters.
Thank you. It looks like Assemblywoman Titus is having some microphone difficulties. Maybe broadcast can help her out. I just wanted to take a moment to welcome everybody to our newly established Interim Joint Standing Committee on Health and Human Services. I'm very excited for the opportunity to be chairing this committee. I'm grateful for Vice Chair Doniate and his participation in helping set up these meetings and coordinate. I also want to just briefly thank staff so much for helping ensure that we have all the folks on this meeting today that are here to present to us, and also extend a thank you to all the folks who are watching and are participating today in their various roles. A couple of housekeeping announcements before we begin. Agenda items may be taken in a different order than listed. 2 or more agenda items may be combined for consideration. An item may be removed from this agenda or discussed or discussion of an item on this agenda may be delayed at any time. The committee meeting material can be found on the Nevada Legislature's website. Sorry, I have a hair hanging out in my eyelashes. You can also sign up for electronic notifications related to any activity on the committee's website. We will have a public comment period at the beginning and the end of the meeting. Public comment is limited to 2 minutes per speaker to allow for everybody who wants to participate. This virtual meeting format is important to keeping everyone safe during the COVID-19 pandemic. Members of the public may provide comment in 4 different ways, which are listed on the agenda. You can call in, the call-in number is listed on our meeting page and on the agenda. You can email comments to hhsinterim@lcb.state.nv.us. You can mail in written comments to the research division. That address is also on the website and on the agenda. You can fax comments. Yes, we still have fax. Finally, I would like to remind members to please turn off your electronic devices and remove them during the meeting. Please also pay attention and mute your microphone as you can while not speaking. Just helps us keep down those unintended noises. And with that, I would like to move on to brief introductions of our members and staff. Members, if you'd like to introduce yourself, please include the district you represent and your interest in this interim committee, as well as your goals for this committee during the interim. I do ask that we keep these relatively brief because we do have a dense agenda today. So I will go ahead and ask Senator Doniate, Vice Chair Doniate, to please start us off.
Thank you so much, Chair Peters, and good morning to the committee members. Senator Doniate, representing Senate District 10, which is in central Las Vegas and covers the Las Vegas Strip. My interest here today is I have a background in public health, graduated from UNLV with my bachelor's in public health and currently work as a health administrator. So looking forward to working alongside all of you to address the COVID-19 pandemic and what the blueprint of public health looks like in our state beyond this. Thank you.
I'm going to move on through the senators and then we'll move through the assembly members. So, Senator Harris, would you please introduce yourself and then we'll go on to Senator Hart.
Thank you so much, Chair Peters. It's a pleasure to be with you all today. I'm Senator Harris. I represent District 11 in the southwest part of Clark County. I served on the Standing Health and Human Services Committee last session for the first time, and so I'm really looking forward to following through with a lot of the good work that we started and laying the groundwork for what needs to be done next session. Thanks.
I'm Joe Hardy, family physician, work at Touro University Medical School. Grateful to be on this committee and look forward to helping everybody have good health and positive outlooks for the future. Appreciate it. Thank you.
And go ahead and move on to Assemblywoman Gorlow.
Thank you, Chair Peters. I am Assemblywoman Michelle Gorlow. I represent Assembly District 35, which is in the southwest of Las Vegas. I have served on the Health and Human Service Committee for both of my terms, and this is my first time being on the Interim Health and Human Service Committee, and I'm very excited to be here. I've worked with women and children's healthcare issues for about 20 years, and so I look forward to having robust conversations regarding women and children's healthcare issues. Thank you.
Thank you. Assemblyman Ornlicker.
David Ornlicker. I'm a physician and lawyer, and I teach at UNLV Schools of Law and Medicine in Las Vegas. Healthcare reform is a big interest of mine. I teach and write about it, so I'm looking forward to working with this committee on that. My district is Assembly District 20 on the southeast side of Las Vegas, and some of Northwest Henderson.
Thank you. Assemblywoman Titus, do we have sound from you?
Yes, we do. So, sorry for the trials and tribulations of rural Nevadas and access to Wi-Fi. Happy to be on the committee, excited to serve with all of you who are as equally passionate about healthcare as I am. I represent District 38, which is a rural district, most of Lyon County, all of Churchill County. I'm a family practice doctor, also remain the county health officer for Lyon County. So as you can all imagine, it's been a very dramatic couple of years for, I think, all of us in the state of Nevada, but especially those in healthcare. And so I'm looking forward to working in a bipartisan way to help solve some of these
Thank you, Assemblywoman. Assemblyman Hayden, I think you are last up.
Good morning. Assemblyman Gregory Hafen from Assembly District 36. I'm going to echo what my colleagues have stated and just add that I'm hoping that we're able to use this interim committee to help address some of the shortages in the medical field, both through what's being called the Great Resignation across the country, as well as some of the issues through rural Nevada and getting access to medical staff and doctors. And a little bit of my background is I currently sit on the Desert View Hospital Board in relation to healthcare. Thank you, Madam Chair. Thank
you. This hair on my eyelashes is starting to drive me crazy, you guys. I might have to step away for a second. I am Assemblywoman Peters. I'm excited to be chairing this interim committee. I vice chaired the Assembly Session Committee on Health and Human Services and was really grateful for the opportunity to dive into the issues that are relevant to healthcare in the state of Nevada and beyond. I'm really excited for the agendas that we have planned out for this session. And I'm really looking forward to the varying discussion that I believe we will be able to have during this interim. We do have a relatively brief interim, I think only 8 meetings, and we are trying to get through quite a bit of material and information. So I think, and I encourage my colleagues to reach out and continue working on other issues and doing deeper dives into issues as they come up and your interest is piqued. We have so many stakeholders in the state who are interested in healthcare, and there's a lot to take on. My background is in environmental engineering, but I have educational history in environmental toxicology and a familial history in working in healthcare. Both my mother, my grandfather, my stepfather, and my grandmother have been in the healthcare industry. So I grew up exposed to the healthcare, particularly mental health care needs of Nevada for most of my life. I also grew up both in Reno and in Lyon County. So the perspective of our rural communities is really important to me that we consider and ensure we're including those folks in our discussions. You know, our healthcare deserts are dire across the state, but it is particularly highlighted in our rural communities. I do want to make some statements about my expectations for this committee. I do expect us to show professionalism and fairness to our colleagues as well as our stakeholders and presenters and public commenters. Please treat all folks who are part of this discussion with courtesy, and we are open to all ideas. And I just want to ensure that you know I take transparency and accountability very seriously. So please, if we miss something, point it out, help us out, help make sure that this committee is being held to that standard. Next, I would like to have our committee staff do introductions. We have a wonderful committee staff here to support this interim committee. And I'd like to give them a brief opportunity to state who they are and how they will be helping us. I'm going to start with our senior policy analysts, Patrick Ashton and Christy Robusto, please.
Well, thank you so much, Chair Peters. Good morning, I'm Patrick Ashton. And I work as a senior policy analyst with the research division of the Legislative Council Bureau. This is my 3rd legislative interim. I assisted the Legislative Committee on Healthcare and the committee to study the costs of prescription drugs during the past interim. Last session, I also served as the committee policy analyst for the Assembly Health and Human Services. Just some background about myself, I hold 2 master's degrees from UNR, one in political science with a major in public policy, the other one in social work. And I'm also a licensed social worker and work for the Aging and Disability Services Division at DHHS and the University Center for Autism and Neurodevelopment at UNR before I joined LCB. I'm originally from Munich, and you can notice my accent, my German accent. But since 2009, I have enjoyed living in Nevada for most of the time. So I'm really honored to serve as your committee policy analyst. I look forward to this interim, and thank you so much.
Hi there. Thank you, Chair Peters. Good morning. This is Christy Robusto, also Senior Policy Analyst with the Research Division of the Legislative Council Bureau. I joined the Research Division in March of 2020 and then served as the Committee Policy Analyst for the Assembly Education in this past session. And this is my first interim with the Health and Human Services Committee. A little bit about me. I have a PhD in public health with an emphasis in health behavior from UC San Diego, where I also completed a transdisciplinary training predoctoral fellowship that added biological and biomedical background to the degree, and a master's in exercise physiology. And then after moving up here from San Diego, I worked with Nevada's Division of Public and Behavioral Health for almost 5 years before joining LCB. And just like Patrick, I'm very excited and honored to be serving the committee this interim and really looking forward to working with you all. So thank you very much, and let us know if you need anything.
Thank you both. Next, I'd like Mr. Kucera to introduce himself.
Good morning, Chair Peters, members of the Interim Committee. My name is John Kucera with the Fiscal Analysis Division of the Legislative Council Bureau. I am primary staff for our Interim Finance Committee, but I am secondary staff for this Joint Interim Standing Committee on Health and Human Services, and I'm happy to address any general budget or fiscal related questions or concerns as they may arise. Within the fiscal division, we generally segregate responsibilities by executive budget. And within the fiscal division, there are several analysts that share responsibility for the Department of Health and Human Services, given its size and scope. So if I'm not able to address a specific concern, I'm happy to take it back to an appropriate subject matter expert and communicate responses to these members. My educational background includes a BSBA in economics and a master's of public health with an emphasis in epidemiology. And I look forward to working with and serving all the members of this committee. Thank you, Chair.
Thank you. Mr. Robbins, would you like to introduce yourself?
Hi, I'm Eric Robbins from LCB Legal. I am legal counsel to the committee. I've been with LCB Legal since 2012, and I have staffed Senate Committee on Health and Human Services and the Interim Legislative Committee on Healthcare, which was the predecessor to this committee since 2015. I also staffed the Legislative Committee on Seniors, Veterans, and Adults with Special Needs. In addition to my law degree, I also have a degree in biomedical basic sciences. And I am looking forward to working with all of you.
Thank you. I'm always so impressed with the resumes of our staff. LCB really is one of the most wonderful groups of staff to work with. And I want to encourage all of the members of this committee to please utilize our staff. If you have questions or comments, if you have issue areas that you would like to explore within the health field, our LCB staff is just fantastic. Additionally, in this committee, we receive assistance from our two research policy analysts, Julianne King and Crystal Rowe. You will likely receive emails from all of these staff members at some point in time. So I would also recommend favoriting their email addresses so that you can ensure you're getting those emails. So thank you, LCB, just one more time for all that you do. We really appreciate you and look forward to moving forward in this committee with your help. Next on the agenda is public comment. I would like to go ahead and start our public comment for the beginning of this meeting.
Thank you, Chair. Good morning. If you would like to speak in public comment, please press raise hand in your Zoom window or *9 on your phone to take your place in the queue.
No, I failed to give a little background on our public comment process this morning. So while we're waiting for people to queue up, I would just like to say, to reiterate that we are limiting public comment to 2 minutes per speaker. Staff will be timing each speaker during public comment to ensure everybody has a fair opportunity to speak. We also ask that you do not repeat what a previous commenter has stated. If you do feel inclined to ditto, that is great and fine, and we will take that into consideration as well. An additional opportunity to make public comment will be available at the end of the meeting. Our broadcast and production staff will interact with those making public comment and providing testimony to facilitate participation in the meeting. So BPS, if we can please add the first caller to the public comment.
Thank you, Chair. Caller with the last 3 digits of 918, you are unmuted. Please continue.
Thank you. My name is Leanne McAllister, LeAnnMCALLISTER. I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics. Thank you for prioritizing discussing the COVID-19 pandemic at today's meeting. The Nevada AAP strongly advocates that we should prioritize having students physically present in school. This must happen with careful measures to keep students and staff safe. All students and staff who are eligible for a COVID-19 vaccine should get vaccinated. We also urge families to make sure their children are up to date on all vaccines. The last thing we need as we work our way out of this pandemic is an outbreak of another vaccine-preventable disease. Nevada families are invited to share with us how they feel about all vaccinations on our parent survey on nevadaaap.org. In addition to vaccines, to best protect students, teachers, and staff, All children over the age of 2 years and all adult staff should wear face masks, regardless of whether they are vaccinated. Lastly, this pandemic has exacerbated an existing mental health crisis among children and teens. Nevada AAP pediatricians are prepared to offer resources to help families, schools, and elected leaders. The Nevada AAP currently has 274 members, most of whom are board-certified pediatricians, both primary and specialty care. Members also include pediatric nurse practitioners, physician assistants, pediatric residents, and medical students, all of whom live and work in Nevada and have dedicated their professional lives to the health of all children. Thank you.
Thank you. Can we have the next caller, please? Yes, did I lose you?
Mr. Moraski, you are unmuted. Please continue.
For the record, this is Dr. Jeffrey Moraski, Jeffrey MuraskY, the Chief Medical Officer for HCA Healthcare, Sunrise Children's, Mountain View, and Southern Hills Hospitals. I appreciate the opportunity to address this interim committee. I wanted to share with this committee a brief update on how our 3 hospitals are doing, as it's no secret that COVID is surging again in Nevada right now. While Omicron variant cases cause less admissions, we currently are seeing the most number of cases in our hospitals and a high volume of non-COVID care at the same time. Unfortunately, 80 to 85% of those we're seeing admitted are unvaccinated. We continue to experience staffing shortages, just as the national crisis has shown across the country, but this hits us particularly hard in Nevada. Our infection rates are high, and these staffing shortages together create the perfect storm of full emergency departments. We wanted to make sure the committee also understood the impact that these staffing shortages have on our partners in the post-acute care space, like nursing home facilities and home health, where patients can't have nowhere to go when they leave the hospital. Currently, we have over 100 patients alone at our 3 hospitals who are waiting for such placements. Many of the issues this interim committee will look at today and over the course of the next year will have a significant impact on our ability to provide life-saving services to Nevada patients. In particular, Sunrise Hospital is the #1 provider of Medicaid services in the state, caring for Nevada's most vulnerable population, and they take this responsibility very seriously. As you consider issues related to Medicaid and the pandemic, we ask you keep in mind the impact your decisions will have on our ability to provide these services. We look forward to working with you on these important issues, and please consider us a resource. And lastly, I think we have reason to be optimistic as we anticipate a sharp decline in the Omicron surge, but wanted to remind the public, as has been stated, the importance of vaccines and boosters, diligent hand washing, and mask wearing, but also wanted to remind folks to continue to get flu shots and consider donating blood. Thank you, Chair Peters.
Thank you for that update. Next caller, please.
Good morning, Chair Peters and Vice Chair Donate, honorable members of the Interim Health and Human Service Committee. For the record, my name is Eddie Abelister. I'm representing the Nevada Dental Association this morning. I want to speak to you regarding Regulation R035-21, which is proposed by the Board of Dental Examiners. With the current pandemic and the significant need for our many qualified healthcare providers in the community, the Nevada Dental Association supports the idea of expanding vaccination duties and responsibilities to trained healthcare professionals who work in the oral health industry. But we do have concerns over the current language as submitted to your committee this morning. The Nevada Dental Association has submitted a letter outlining their concerns, and we have attached language that was previously worked on in March of 2021 when we sat down with the Nevada Dental Hygienists Association, the Oral Health Committee, and the Division of Public and Behavioral Health, as well as the Immunization Division, and sort of created a document, as you will see, with changes that were all mutually agreed upon. We ask that the Interim Health and Human Service Committee sends recommendations back to our Board of Dental Examiners to collaborate with these stakeholders on these changes before sending it to Ledge Commission for adoption. I have reached out and am continually working with the board's lobbyists to fix some of the redundancies, contradictions, and confusion in the current language. We appreciate you taking this up this morning with your thoughtful time and attention to review this important issue and to help fix possible future and current public health issues that arise in our community by adding more providers into the queue. Thank you for your time this morning.
Thank you. And next caller, please.
Caller with the last three digits of 597.
Hi, my name is Charlotte Stewart, and I am with Health Freedom Nevada. And I am calling to kind of point out, the other day, Senator Johnson had a meeting with the Senate, and it's been confirmed that early treatment of COVID-19 with ivermectin, hydroxychloroquine, and other protocols used by the frontline doctors has saved thousands of lives, hundreds of thousands of lives. I ask that in this state, you guys start looking into other options, not just vaccines. Not everyone can take a vaccine. The vaccines have not been proven safe. There's several side effects from them, and we don't know the long-term side effects. Forcing them on children could be detrimental. It could cause sterilization. And from what I know, they use protein from HIV in some of the vaccines. If you do not believe me, that will be coming out in the news very soon. I don't think that there should be mandates for things that harm people. That is ridiculous. This pandemic has been handled terribly from the beginning. And the use of remdesivir in the hospital is killing people. You guys need to get your ducks in order and start prescribing early treatment to everyone in the state. Please and thank you.
Thank you. I just want to take a point of privilege to encourage folks to look at peer-reviewed material when they are looking at the COVID-19 pandemic and any medical issue.
Hello?
And would encourage that people take that peer review very seriously. Next caller, please.
Hello, I'm sorry, there was like a lot of background noise in there. This is Casey Rogers, CASEYRODGERS. I'm calling about the COVID-19, anything that's on this agenda that has to do with COVID-19 or SARS-CoV-2. The science is clear. The virus is spreading despite the scam mask that you have all forced onto the public. It is all theater, and you are demanding it of people when the science has already told you through the years prior that these viruses pass through these masks. Not only do they pass through the masks, it's even been verified by the frontline doctors and many other doctors and independent doctors right now, as well as I would just like to say the vaccine, on the other hand, that we will discuss now. Why are the vax still getting COVID? Breakthrough cases is a way of telling you your genocidal vax is not working. If you need 3, 4, 5, 6 boosters, it's telling you it's not working. You need to stop this genocidal agenda now. You have the CDC has changed the definition of the ethics, the definition of vaccine, and everything else to fit its agenda. The definition of in name only is by description, but not in reality. Let me ask you a question. Where is Comirnaty, the so-called FDA-approved vaccine being used in the United States of America? Please inform your public. Let us know, where is it at? Because everything else is still under EUA. And you guys are force vaccinating the entire country against what you should be doing. And you know it. Where are all the ingredients? Let us know. Quit hiding. Your theater is crumbling. People know the scam. and the doctors and educators participating in it will be held accountable. Thank you.
Next caller, please.
If you recently just joined us, we are currently taking public comment. If you would like to speak in public comment, please press *9 now or raise hand in your Zoom window to take your place in the queue. Chair, you have no more callers wishing to participate at this time.
Thank you. And thank you to folks who called in. I know that it takes bravery to make those calls and to offer those pieces of our either opinion or advice. I do feel like it's important for us to talk about the importance of science and research and HHS in particular. Those are the governing bodies of why we make public health decisions. So peer-reviewed articles are the best place to find information. And if you need help finding information, you can reach out to our research analysts, to our legislators, and to our Department of Health and Human Services to ensure that their decisions are made based on that peer-reviewed information. We'll go ahead and close the public comment period. We will have another public comment period at the end of this meeting if people so desire to call in at that time. Next, we will move on to agenda item 3, which is the consideration of regulations proposed or adopted by certain licensing boards pursuant to NRS 439B.225. Eric Robbins, please go ahead and begin with those regulations.
Hi, Eric Robbins from LCB Legal. So as the chairwoman stated, the Joint Interim Standing Committee on Health and Human Services is required by NRS 439B.225 to consider regulations from certain licensing boards at state agencies that license healthcare providers and healthcare facilities that pertain to the requirements for the issuance or renewal of a license, certificate, or similar credential by those boards and agencies. And the committee doesn't take formal action on those regulations, but the committee can make informal recommendations, and also if the committee felt strongly enough, they could propose legislation at the interim at the end of the interim to address concerns with any of those regulations. But we have representatives from all of the agencies who attending the meetings to answer any questions that members of the committee might have concerning the regulations. And the last thing I wanted to make clear is that this is separate from the formal approval process that goes through the Legislative Commission, but the committee can provide feedback to members of the Legislative Commission concerning the advisability of the regulation. So with that, I will ask if any of the members of the committee have any questions concerning the regulations, and if so, then we can get the person from the representative from the agency up to respond to the question.
Madam Chair.
Assemblywoman Titus, please.
Thank you. I have some questions regarding the Board of Pharmacy regulation R08520, and I have a question regarding the dental board regulation, and I'd appreciate if I had had an opportunity to ask those representing those two groups would be available.
So, folks from the Board of Pharmacy regulations, we can start there. I believe that we have.
Madam Chair.
Yes.
Are we going to go through the regulations one at a time, or are we going to have the Board of Pharmacy come up and talk about all 3 or 4 of their regulations? How are we going to do this?
I'm going to ask for a 1-minute recess real quick. All right, coming back to it. We have quite the stacked agenda today, and those regulations were sent out to everybody before the meeting started. So if we have specific comments on those regulations at this time, we can ask the folks who are here representing those boards to speak to those questions based on those regulations. Again, we are not making decisions on these regulations today. You can bring questions to them in the future if those come up for you before they are officially moved on in the Legislative Commission and adopted. So does anybody else have other questions that we can queue up for our boards before we ask them to come up? Assemblyman Ornlicker, can you let me know who it is that you would like up here?
Yeah, I have a question about agenda item, I think it's 3C, dealing with chiropractic licensing.
Thank you. And Senator Hardy, you had questions?
Yes. On my Joint Interim Standing Committee Human Services presenter list, it didn't match the numbers of the presenters with the numbers of the regulation. So I only had questions about Amir Brigand's timeline. Then the next one was the interns, then the next one was the ethics, and then I didn't have any challenges or questions with the drug alcohol, but did with the Board of Occupational Therapy and the chiropractic board and the dental examiners and the Board of Pharmacy with their 1, 2, 3, or 4 different regulations proposed.
Okay, Senator Hardy, will you can you give me the item numbers that you want pulled up?
So this is what I got, and then it doesn't match with the item numbers. So while you're listening to other people, I'll try to make that correlation with what they are as to the regulations.
Okay. Thank you.
Madam Chair, this is Dave Weiss from the Board of Pharmacy. I'm prepared to talk about all 4 of the regulations when you're ready, and I can give the numbers at that time if that helps you.
Great. I think that's a great place to start. Let's go ahead and start with the Board of Pharmacy questions. And I had Assemblywoman Titus queued up for a question. And is there anybody else that I missed, legislators who have questions on these? Okay. Yes, we'll go ahead and start there. Thank you, Mr. List.
Thank you, Madam Chair, and thanks for everybody's service on the committee. I'll just do a brief summary and then I can answer any questions. So I'll start with Dr. Titus's question, R085.20. This is a regulation that the board is proposing. It's currently through public hearing, and it is related to recovery room centers. So as we've seen the hospitals become decentralized a little bit, we begin to see surgery centers that got licensed with the health department, and now we've seen recovery room centers. So these are just like the recovery room center that's at a hospital, but they're outside the hospital. They're licensed by the health department, and as you gave us permission, the legislature gave us permission in the 2019 session, if the Health and Human Services adopts a new license type and they need a license from us in order to manage the drugs with the DEA and with the manufacturers and all those other things, we can propose a new license type. So this is it. We work closely with the industry. I think we have 3 recovery rooms in Nevada now, and this is a proposed regulation that would get them licensed. I can answer any questions.
Thank you, Chairwoman, for allowing me to ask the question. Sir, I really didn't need all of that because I could read the regs also, and I understand the concept. All I wanted to do was ask a brief question, and that is, tell me the purpose and what they do in the lining of the euthanasia technician.
So sorry about that, madam. The euthanasia technician that is along with that part of the regulation is a license type that the states had for many years for licensed people with the veterinary board that can possess certain controlled substances in order to euthanize an animal. And so we're just tidying it up. Their old license allowed them more access to the drugs that they needed to euthanize the animal. Now we're just saying these are the animals. So it already was a license type, just paring their spectrum back a little bit to make sure that they didn't have other drugs that they didn't need.
Excellent, thank you. That wasn't a term, I assumed it was for the veterinary board, but I wanted to confirm that with previous discussions that we've had regarding end of life for humans. So I want to make sure it was still within the role of just the veterinary board. Thank you. That's all I have for the pharmacy board. Thank you.
Senator Hart, thank you. Senator Hardy, do you have questions for the Board of Pharmacy?
That answers one of them on the euthanasia issue. The other question I had is on the auto dispensing. We talked about putting different languages on the bottle, or how is the auto dispensing going to do the kinds of things that we're trying to tell people in a different language, or how are we meshing those ideas?
Yeah, thank you, Senator Hardy. Just for the record, Dave Weiss, Executive Director of the Board of Pharmacy. This is LCB file R013.21. These items would, what we're talking about here is a automated machine that you've seen before, I'm sure, that can be placed at certain locations that can actually end up dispensing the medication. We've seen them in emergency rooms and other things around the state. We're expanding where those can be and writing some more rules for them, as Senator Hardy pointed out. So as it relates to the Senate bill last session regarding to languages, they would have to comply with that, sir. So the machine will have to be able to communicate to the patient, figure out what language it needs to be on there, and that would have to be, the language would have to be on the bottle.
All right. Is that a process that works somewhere?
The machines or the language?
Yes.
Okay, the machines are commercially available. As I said, we're, like many states, expanding the use of them, or at least allowing the rules to expand the use of them so that they could be placed at more places where people don't have access. The language, I've not seen it with the machine, but that's obviously, this is just for this. It has not gone to public hearing yet, so this is not the final language that we will probably see when we get to the Legislative Commission. But the language itself has been done in Oregon, a little bit in California, and I think we're the 3rd state to do it. We're progressing on that language, and you'll see that at Legislative Commission at some time.
So I looked at one of those automatic places that measure the weight that goes into a 90-day prescription as before it's sent out, and I'm wondering if the weight of that is going to be taken into account of the translation of languages may be more printed than something else. And so would a different language change the weight, and are they going to actually have to figure out how to do the weight without the language and then put the language on, which is a double step in trying to put language on, or I would find it difficult to do, not impossible, obviously, but difficult to do the different languages at the same time they're filling the bottle. I think it's going to take a new conveyor, or that may be done by hand. Is it going to preclude the hand adding a language, or is this going to be just the medicines itself, and then later a different system can be used to add the language to the bottle so as not to create a whole new atmosphere of the production line?
Excellent question. So the weight technology is already used in the pharmaceutical industry, not necessarily on these machines, but there might be some that do. I'll cover that. The weight is measuring the vial and then the tablet to make sure accuracy. And we see that in some pharmacies that are traditional pharmacies right now. These automated dispensing systems that we're talking about here are generally pre-loaded bottles that just have the pills in them or the eye drops in them, and then the machine actually puts the label on them. So I haven't seen ones that use the weight exclusively to determine, because the pharmacist, prior to him going into the machine, is counting out the pills and putting them in the bottle, 30 pills, like doing a pre-packed, which you're very familiar with, pre-packed, and then it just goes in there. So we'll have to watch that for the weight. I don't think there's not loose pills that are just being put into a bottle by most of the machines. They're pre-packed forms. Some are commercially already available and they're just slapping the label on it. They would have to put the language on it.
I appreciate that. And Madam Chair, let me ask it this way. What Dave Wiest has said is this is going to go to a public hearing as opposed to this hearing. Is that the case with all of these proposed regulations? Is these are for us to say something before they actually have the public hearing? Is that correct?
Dave Wiest for the record. So for mine, I have two that are still going to public hearing, and I have two that have gone. I pointed that out. So the one with the euthanasia tech has gone. And then the two, the one I'm talking about here, and also the one, I apologize. The euthanasia tech is the one going to public hearing March at the March board meeting. And this is going to public hearing. The other two are going, will go to LegCom. So, and we always appreciate your feedback and, more importantly, direction. So it's never too late to give us some advice on how you want things done.
So then I'll ask you, Madam Chair, do we know the differentiation between what we're seeing today as to if these have gone to public comment by the agency versus what are going to be coming to Legislative Commission?
I'm going to ask that Eric Robbins, our staff, answers that question and give us a brief description of how, like, the status of these and where they'll be going. I also will ask that staff follow up with us on these regulations to give us a status of where they are and where they will be for the next public comment or decision.
Eric Robbins, LCB Legal, for the record. I can't comment on the regulations that are still in the proposed stage. Whether I don't know whether the agency has had a public hearing on those or not yet. I think as Mr. Wiest was saying, some of them they have and some of them they have not. If the regulation says that it on the top of the regulation that it's been adopted, then the agency has heard the regulation, had all their public hearings and adopted the regulation, but the regulation has not gone before the Legislative Commission yet. So that's the stage that would be in. If the regulation is approved, then the regulation has been both adopted by the agency and gone before the Legislative Commission and is effective now. So if the committee had concerns with that, the members of the committee could recommend changes, that the agency adopt another regulation, changing the regulation, or propose legislation at the end of the interim to address their concerns.
That's helpful. I appreciate it.
Senator, I'm going to ask that our staff follow up with us on these regulations with the status of where they are, so that we have an idea of the process that they're all in, and they can work with the different boards on that piece so that you will know and be able to participate in those areas if you would like to. I would like to move on to the next set of regulations up for question. That would be the Board of Dental Examiners.
Morning, everyone. This is Phil Sue on behalf of the board.
Thank you, Madam Chairwoman. May I go ahead?
Please.
Thank you. So I appreciate, again, the opportunity to ask a question. And first off, I want to point out that when I looked at these regs that you are proposing, the dental board, they were eerily familiar to almost exact wording of Assemblyman P.K. O'Neill's bill that never got a hearing, I might add, at the last session, AB 269. And that, as the representative from the Dental Association pointed out, was worked on by multiple groups, including the dental hygienist, the dentist, and those associated, to come up with a better rendition of that bill and the amendment version. But I'm wondering why the original bill was put in, but not the amended version that all had agreed on. And I'm wondering if you had reached out to the folks that are being affected by this before this current regulation was presented.
Sure. Again, for the record, I'm Bill Sue, General Counsel and Interim Executive Director of the State Board of Dental Examiners, and I thank the committee and Chair Peters for the opportunity to speak with the committee. As to your particular question, my understanding of the history of this particular regulation, it was first proposed as an emergency regulation back in December of 2019, or 2019, no, 2020, I apologize. So it was before the legislative session. I think we were, I actually am unaware of why the amendments from the Assembly Bill 269 language were not incorporated into into the regulations that the board had proposed. It wasn't something that was shared during the December 2020 workshop. For history's sake, just so the committee is aware, I worked closely, and first of all, I want to thank Dr. Capurro. She was a state dental health officer at the time, and she and I worked closely to try to craft regulations to permit dental licensees to administer vaccinations in light of the situation that the state was in. So I guess in short, I don't know why the amended language from AB 269 was not incorporated into the bill, into our regulations. It wasn't something that was brought up previously in the workshop or in any form, either finalized or otherwise.
So follow-up question, Madam Chair. I would just like to ask, and first, thank you for that. So you did have a public workshop on that where folks could come and comment on these regulations?
We did, January 7th, 2021, okay. 2020.
Okay, and then second, so Dr. Capurro was involved in the current regulations that you're presenting?
Yes, let me clarify. I apologize. It was January 7th of 2021, and previous to that, I had certain discussions and email exchanges with Dr. Capurro. Frankly, the language that we used was in large part borrowed from similar language that the Board of Pharmacy had proposed for their pharmacy technicians to administer vaccinations.
Okay. So I appreciate that. And I just want to make sure that all folks are, or that especially those that are affected, I'm in favor of the what the dentists are, what you're trying to do, allowing the dentist to properly trained and to administer these vaccines. I think it's appropriate. However, I just wanted to make sure, again, that regulations aren't being passed without proper input from those that are being affected. So thank you, Madam Chairwoman, for the questions.
Thank you. And I think that there may be a timeline discrepancy because of when we were working on those bills during session in 2021, which would have been around probably the March time period. So that would have been after that public input session happened in January of 2021, if those dates are correct. So there may be some additional work to be done on those. Senator Hardy, I saw your hand up for the dental examiners.
Yes, thank you, Madam Chair. We came to this before with the Board of Pharmacy, and we put in statute that a student, a pharmacy student, was allowed to give immunizations. And it probably would behoove us to recognize that if we're having dentists do vaccinations, we probably ought to allow dental students to do immunizations because they have to be taught what they're doing and where they're doing it. So I think it'd be wise to recognize that if dentists are going to do it, we probably ought to train the dental students and allow that to happen as well.
Thank you.
Thank you very much, Senator.
Are there other questions for the Board of Dental Examiners? Seeing none, I would ask that we would move on to the next board, the chiropractic physicians, it looks like. Have the next question, which I believe comes from Assemblyman Orentlicker, if you would.
Yes, thank you, Chair Peters. And the question I have on this proposed regulation is on page 3. It's section 1, then subsection 2, B as in boy. So there are a couple of things. I'll start with the first question. And it refers to, so it says the board will not issue a license or by endorsement if they look at the report from the FBI for the applicant's criminal record, and the person's been convicted of a crime described in this other section, and the board has not previously taken disciplinary action. So my question is, if the FBI report includes a crime committed in another jurisdiction, and the board in that jurisdiction has taken action, would this applicant be precluded because our board hasn't taken action?
Thank you for the question, Assemblyman. My name is Julie Strandberg. I'm with the Chiropractic Physicians Board, and that language is just merely taken from NRS 622. That NRS 622 requires all boards to establish this in our regulations, in the board's regulations. So I can speak to how our board has handled situations like that in the past. Is if a board has taken action against licensee and they're coming to our state, we do look into that information and address it as needed, depending on their status with the state that originally disciplined them.
Okay, so that sounds like you weigh it as a factor.
That's well, as far as this goes, we haven't addressed it as it speaks to in this specific statute. However, in our chiropractic laws, as we've used them in the past, that's how we've addressed those things, depending on their status with their licensing with the state that they've been disciplined in.
Okay.
So
Yeah, so my concern is it says you will not issue a license, and you're saying that's required by statute, but that doesn't seem to give you discretion to say, well, we looked at it, they were properly, this was properly addressed in Pennsylvania where they're coming from. And so that the statute, this regulation, and maybe the statute doesn't seem to allow you that discretion. Is that the problem?
That is my understanding as well. In this, as this goes, you're right. And since we haven't come upon that, I'm not certain how, with legal, how we would particularly address that circumstance.
And then my second question was about the reference to the NRS. It says, convicted of a crime described in subsection 3 of NRS 634.140. So I looked at that subsection and it has a few parts to it. And the last part, I think it was the crime of moral turpitude. And I didn't see a definition of that, but I know that often it's an art used, it has an art long history, and sometimes it has an archaic definition, and I wasn't sure if the term there might sweep too broadly, as sometimes that term does. Do we know how that is interpreted for this regulation?
Again, Julie Strandberg for the record. And again, this language is merely taken from NRS 622, as all boards have this in their regulations. So I'm sorry that I can't particularly address that without speaking with legal and LCD legal in this case, because that's their broad NRS for all boards to adopt.
Thank you.
Sorry, I can't answer.
No, thank you. Thank you for the question, Assemblyman Orlicker, as well. And I think you can ask for follow-up from our staff, Eric Robbins, if you're interested in pursuing that piece for all boards. We have one more request for questions from the Board of Occupation Therapy. I would ask that this question be brief. It looks like that came from Senator Hardy, if you'd like to go ahead.
I was actually on the chiropractic board.
Do you want to? So we have a dense additional agenda. So I'm hoping that we can move through these quickly. So if your question can be brief, I would appreciate it. And if we could get Ms. Stanberg back for Senator Hardy's brief question.
I was smiling when Assemblyman Orlicker talked about moral turpitude, because that has come up with other boards as well, and we tried to figure that out. So I think it's a work in progress. Well, all of the boards, if they still have that in there. But then I looked at one man's crime in one man's state is different than our state, and in this period of time where we are decriminalizing things, we probably are going to put some people out of competition for jobs and moving to Nevada because they have been accused of smoking a joint someplace elsewhere, and now they have a crime and they've been convicted and but yet they've been freed, and yet they've been expunged, and et cetera, but nevertheless, there's no leeway or give, it seems like, that we're seeing in this particular thing. So I have reservations about that particular one as well. Thank you, Madam Chair.
Your comment. I think this is again another opportunity to chat with our LCD legal on the implications of these pieces for all boards that adopt these regs. I cannot remember who asked for the Board of Occupation Therapy, so please remind me if that was you and you had a question for them. Was that Senator Hardy or
Hi, sorry, I'll be right there. Sorry.
Or Assemblywoman Titus?
brought it up, it was about the telehealth for occupational therapists. And I think I've been okay with what we were seeing, and I'll just take a further look at it at another venue. Thank you.
Thank you. I appreciate that. Again, I'm going to have staff follow up with us on the status of these regs and where you can find the next opportunity for comment or decision on these. With that, I'm going to ask staff, is there anything else that we need to do under this particular item?
I did have other questions and I'm not sure which one it was, but the Division of Public Health and Behavioral Health, on the top of my number 3 that wasn't actually in order, when we start taking the timeline and the grandfather clauses that don't exist, are we going to have enough caregivers, was my question, when we start requiring things that heretofore haven't been required? And I apologize for not knowing which one it was, because I thought we were going to just kind of discuss each one of these. And so that's one of my challenges. And then with the speech, language, audiology, hearing aid dispensing board, I understand that they're going to require 10 hours of ethics. And I think that's RO 64-21. When you start requiring 10 hours of ethics, quite frankly, I do a lot of CMEs, and in the medical world, we require 2 hours of ethics every time. And so I think some people struggle to find enough ethics qualified continuing medical education type courses to get 10 hours of ethics. I don't know if we are trying to overshoot what is necessary for the ethics of that, and I have concerns about that. Ethics are fine, but there comes a point where it becomes a practical thing. Where are you going to get those 10 hours? And that's my concern on that one. Thank you, Madam Chair.
Out of those two concerns, are there folks from those different entities interested in responding? I see Paul Schubert with DPDH available for that first comment. And if I'm going to ask that we make the responses brief as possible so that we can move on to our other agenda items, please.
Yes, Chair Peters, it's Paul Schubert with the Division of Public and Behavioral Health. And with regards to our 056-20 and the requirements that we're implementing in those regulations for additional training, what I would say is that there are already requirements for the number of hours of training within the current regulations. These are just modifying the subjects that will be necessary and in order to implement actually the Senate bill from the 2019 session, Senate Bill 362. So I hope that addresses the question. If not, I can respond further.
Thank you for the response. I have Jennifer Pierce on as well, which she is ready to respond to, yes, the speech language pathology, audiology, and hearing aid dispensary board regulations. Please.
Thank you. Good morning, Chair Peters and members of the committee. For the record, my name is Jennifer Pierce. I'm the Executive Director of the Speech, Language Pathology, Audiology, and Hearing Aid Dispensing Board. Senator Hardy, I appreciate your question, and I too agree that 10 hours would be way too many ethics, and our board members have also confirmed that it's almost difficult to find a lot of ethics courses. So I just wanted to clarify your comment. Our regulation actually changes our annual requirement to 10 hours annually from the currently required 15, just to align with the national practice standards. And only one of those 10 hours annually was being drafted to be required in ethics. We did hold our first public workshop last night, and the board voted to amend that language slightly. So we'll still be drafting the language to require 10 hours annually And then at least one of those 10 hours would be either in ethics or cultural competency and diversity and equity issues. So to clarify, not 10 hours of ethics in a year. Thank you.
So it will be 9 hours.
No, I'm sorry, 10 hours annually, of which one will have to at least be in ethics or cultural diversity issues.
Super. Thank you.
Yes.
Thank you. Thank you, Madam Chair.
Thank you. Always really interesting to get these regulations, and I appreciate the committee's interest in these. We're going to move on to our next agenda item. I do want to thank all of the board and representatives who were in attendance today to respond to those questions. Thank you so much for your time and for your attention to these details. Okay, our next agenda item 4, is a brief review of the committee's duties and responsibilities. This again is our first committee hearing of this newly established committee. So I'm going to go ahead and let policy staff, Patrick Ashton, take the lead on this one. Thank you.
Thank you, Chair Peters. For the record, Patrick Ashton, Committee Policy Analyst with the Legislative Council Bureau. Just a short disclaimer, as legislative staff, I cannot advocate or oppose any of the proposals that come before you. I'm here to assist the chair and the members with any questions concerning policies that may arise. My colleague Christy Robusto and I are available to assist the committee and its members on any issues related to health and human services. In addition, the research division is available to provide information and assistance on a confidential basis to individual members of the legislature on any topic. So please feel free to reach out to me or my colleagues at any time. I will now review with you the responsibilities and duties of the Joint Interim Standing Committee on Health and Human Services, in short HHS. For that purpose, please find an electronic copy of the committee brief on the committee's meeting page. I'd like to take just a few minutes to cover some highlights. On page 1 of the committee brief, you find a list of the legislators and alternates appointed to the HHS committee, followed by a section on responsibilities of the committee pursuant to Assembly Bill 443. This bill passed during the 2021 legislative session and significantly changed the interim structure of the legislative interim. AB 443 repealed the Legislative Committee on Healthcare. Its primary responsibilities and duties were transferred to the new HHS committee, including reviewing and evaluating the effectiveness of programs to prevent illnesses, analyzing the overall system of medical care in Nevada, and coordinating service provision to avoid duplication of efforts. The HHS committee may also review issues related to health insurance, hospitals, medical malpractice, and health-related regulations, as we just heard right now. Additionally, the jurisdiction and membership of the Standing Senate and Assembly Committees on Health and Human Services are reflected in the HHS Committee. Finally, AB 443 repealed the Legislative Committee on Child Welfare and Juvenile Justice. The review of child welfare issues is now part of the HHS Committee's jurisdiction, and the review of juvenile justice was transferred to the Joint Interim Standing Committee on Judiciary. The HHS committee may request a total of 15 bill draft requests, and 5 of these 15 bill draft requests allocated to the committee are limited to issues that address child welfare matters. Now, page 2 of the committee brief reviews mandated activities of the HHS committee and other priorities of study. During last session, Senate Bill 209 passed, which requires the Legislative Committee on Healthcare to conduct a study during this interim regarding the state's response to the COVID-19 health crisis. Since the responsibilities of the Legislative Committee on Healthcare were transferred to this committee, it must conduct the study now. You will hear more details about the study requirements during Agenda Item 7 today. Generally, for the next 8 months, you can expect presentations about many health and human services issues with a focus on public health and the COVID-19 pandemic, child welfare, including early childhood health and education issues, health insurance with a focus on Medicaid and the public health insurance option, mental and behavioral health, and women's maternal and child health. Next, On page 3, you will find an overview of relevant audits and reports regarding health and human services issues in Nevada. The committee brief contains hyperlinks to the audits and reports if you like to dig deeper in certain issues. On the bottom of page 3 is the list of committee meeting dates for the 2021-2022 interim. Starting today, we will meet every month on the third Thursday of the month, with the exception of the March meeting. Finally, on the last page, you'll find a list of the LCB staff who will provide support for the committee during this interim. Chair Peters, this concludes my presentation, and I'd welcome any questions.
Thank you so much. And thank you so much for putting together that committee brief. It is very helpful to have that all in one spot where everyone can see our expectations and resources for the committee. Are there any questions from committee members on the duties and the committee brief presented briefly there? Seeing none, I'm going to move on to the next agenda item. This is one we've all been waiting for, a presentation on the state of the coronavirus disease of 2019, known as COVID-19 pandemic in Nevada. We have a couple of folks from the Division of Public and Behavioral Health under the Department of Health and Human Services, including Melissa Peak-Bullock, the state epidemiologist, Julia Peak, the deputy administrator, and Kira Morgan, the chief biostatistician. Looks like they have all loaded up. I'm going to go ahead and welcome you to the committee. Thank you so much for being here. Please go ahead with your presentation.
Thank you, Joseph. Hi, so I'm Kira Morgan. I'm the Chief Biostatistician for the Department of Health and Human Services, and I am going to kick off our presentation today by giving just a brief status update on some of our statewide COVID-19 metrics. So if we could jump right in to the slide here, thank you. You'll notice on the next couple of slides, the graphics here are directly accessible through our state COVID-19 dashboard. So I did just want you all to be aware that you can track these independently if you are interested, and that is also embedded on the NV Health Response website. So this slide here is looking at daily new cases, which are coming in currently right about double the magnitude of what we saw last winter. We're looking specifically since December 20th in this update, because that is when we started to see increases in our statewide metrics in Nevada. A lot of states in the country started this winter surge ahead of us, and so we were a little bit delayed, and so all of the updates that I'm going to talk about are really related to the last month of data. So we like to track our cases using a 14-day average that takes out some of the seasonality and weekly reporting and things like that. The 14-day average did increase almost sixfold from an average of 625 cases being diagnosed every day as of December 20th to 4,248 cases being diagnosed every day currently. I would just highlight on the right-hand side of this graph that we are starting to see just very early indications of some stabilization. The growth rate of new cases is slowing down, and so I am hopeful that we are going to see the other side of this sooner than later. Next slide, please. Here we're looking at statewide hospitalizations, which are also increasing in all of our regions currently. That increase has been in the magnitude of 165% since December 20th. We did see the steepest growth occurring immediately after the Christmas and New Year's Eve holidays. And I did also want to reference that Southern Nevada hospitalizations are obviously driving a huge proportion of this. I believe most recent numbers, Southern Nevada accounted for 88% of our statewide COVID-19 hospitalizations. And then just, sorry, to compare that to last winter, we are just right under where we had seen our highest number of hospitalizations statewide. We reached just over 2,000 in December of 2020. However, in Clark County this year, we are currently recording record hospitalizations for COVID-19. Next slide. This is our critical care hospitalizations, intensive care unit, and ventilator use. We've seen increases here too, but not comparable to the magnitude. We do know that this particular variant is less severe, and so we are seeing increases to critical care, but they're not directly comparable to the increase in cases that we're seeing. Our ICU utilization increased about 94% from 165 individuals hospitalized in Nevada to 317 as of day before yesterday. And then for ventilator use, we currently have 167 individuals on a ventilator, which is a 65% increase since December 20th. All of these metrics are heavily concentrated in Southern Nevada as well. 96% of those ventilators are in Clark County, and 90% of ICU utilization is in Clark County. Next slide. This graph here is looking at mortality, which has not increased significantly since this surge, December 20th, started. We're averaging 7 COVID-19 deaths per day. We did go down to about 5, so we're seeing just very, very moderate increases to this measure, and we're not quite sure, frankly, if we'll see that, our mortality numbers precipitate into a significant surge. Some of the states that are further ahead of us are showing increases to COVID-19 deaths, but some countries who are much further ahead of us are not having that effect. There's a couple reasons that our death numbers could be delayed. It is a lagged indicator, meaning that we expect some amount of time to pass between when cases increase and when mortalities increase. Essentially, individuals have to get sick enough to require hospitalization, and then, for the case to actually result in death. There's also a slight reporting delay, which could add to that. But I do, want to anchor to vaccinations, not only preventing infection, but also reducing the severity of symptoms in our breakthrough cases. And then again, preliminary data around the Omicron variant suggests that it presents with less severe illness. Next slide. Here we're looking at new case demographics. I think it's important to understand who's being diagnosed with COVID-19. Again, specifically, since December 20th, the age group of 20 to 49-year-olds account for 71% of new cases. So we are seeing a healthier age range of individuals being diagnosed. 37% of new cases diagnosed were non-Hispanic white. An additional 34 were Hispanic or Latino. So those two groups account for 71% of new cases as well. However, I did include a graphic here that looks at rates per capita. So these are rates per 100,000 individuals by race, ethnicity. And just to kind of track with that for you quickly, the first half of that trend, you'll notice the blue line is really kind of taking the lead and making up a higher proportion of cases per capita. That's our Hispanic Latino population. And then as of about February, March of 2021, we've seen that shift to our Black non-Hispanic population. So even though they're making up a smaller just sheer volume of cases, they are disproportionately affected on a per capita basis with COVID-19 infection currently. Next slide. Here, touching on vaccinations again, Nevada has approximately 52% of our population completely vaccinated. Sometimes we look at that as a percentage of individuals 5 and older because those are the people that are eligible. It increases a little bit when we consider that age group to 55%, and then 62% of Nevadans have at least initiated vaccination, meaning they have some level of protection, although obviously not as strong. We also completed a study recently on December 27th, which was attempting to quantify any level of immunity through both vaccination and or prior infection. And at that time, we were able to identify 68% of Nevada's population who had, again, just any range on that spectrum of immunity from even just, partial vaccination series completed to prior infection all the way through fully vaccinated. I do think that because the surge we're experiencing right now just is so large in magnitude that we'll probably want to refresh this study at the end of January. And so I anticipate that our level of natural immunity in the community is going to go up pretty significantly just based on the number of people currently being diagnosed with COVID. So that'll be an interesting update. Next slide. And then this is my last slide before I hand it over to Melissa. I just wanted to touch a little bit on expectations on the trajectory of cases. We know that what we're seeing is double the magnitude of what we saw in our last winter surge, but we do expect it to last for a shorter time frame. Nationally, some public health agencies are predicting trends will decline in early February. The CDC is, I think they're a little more cautious to not put out a false positive expectation and then not meet that. So they're predicting declines aren't going to start coming down nationally until April. The Office of Analytics, we're predicting that Nevada is actually very close to what I'm going to call our peak, even though I don't love that term. I think that we will probably start seeing declining trends by the end of February. So I did reference in one of my earlier slides that we peaked last year between November 30th and the first week of January. And so just because we reached a point where we stopped seeing that exponential growth doesn't mean that we start to come down from that yet. And so there is going to be a period of time where we kind of hover at very high case rates. I think it's a little bit too early to say with full confidence that we're there right now, but we do have just early indications that we are kind of hitting that level of stabilization in Nevada. So I'm still pretty comfortable saying that we're going to start coming down by the end of February. And then due to the lower severity of Omicron compared to Delta, hospitalization rates are lower than what we saw in previous surges. Again, if you consider those as with respect to new cases, but overall volume is probably likely to surpass what we observed last year. Again, last year we reached just over 2,000 hospitalizations statewide. Right now we're sitting just over 1,800. So it's possible that we just kind of hover really similarly to where we were last year, but we could supersede those numbers. And then hospitalizations will likely peak up to 2 weeks after new cases, just because, again, allowing time for those individuals to reach a level of severity where they might need hospitalization. And with that, I think I will turn it over to Melissa Peak-Bullock, our state epidemiologist.
Good morning, Melissa Peak-Bullock for the record. As Kyra has just illustrated in our data, Nevada is currently facing the effects of the Omicron variant, as is the nation. I wanted to highlight some characteristics of Omicron. It is highly transmissible, more transmissible than the other variants that have circulated previously. It has the ability to evade immune responses, and it has a shortened incubation period, which also takes into account the speed in which transmission is occurring. It has reduced susceptibility to certain therapeutics. And as Kyra has stated, the severity of illness is not completely understood, but data is suggesting an overall milder illness than previously circulating variants. Next slide. Okay, Omicron in special populations. In our K through 12 schools, the characteristics we just described of Omicron are causing rapid transmission within the school setting. This is resulting in a higher number of school-associated cases than what we have seen previously, even in the first half of the school year and last school year. This is also affecting the ability for our schools to remain open to in-person instructions because of instances where a large proportion of staff are unable to report to work. This is causing temporary school closures and distance learning efforts throughout Nevada. And case investigation and contact tracing within schools is becoming unmanageable when the case burden within the schools becomes too high. Related to hospitals, skilled nursing, and long-term care facilities, concerns still exist related to increased staffing challenges in light of Omicron and increased transmission among the vulnerable residents within these facilities. In addition, there is potential for visitors to be a vehicle of transmission in this setting. Omicron also has potential to significantly impact correctional facilities. Staff enter the community and can become infected and can then infect those who are incarcerated. Given the increase of transmissibility and the limited ability to apply social distancing and cohorting within correctional facilities, and you couple this with the vulnerability of the inmate population, there is potential for significant negative impacts. In addition, staffing challenges that already exist are being magnified. Even in light of Omicron, we do have the mitigation measures to slow the spread of disease. We continue to encourage folks to complete the COVID-19 vaccination series and get the booster dose as soon as they're able. Wear a mask consistently and correctly. Get tested for COVID-19 regularly, but especially if you're symptomatic and before you attend any gatherings. Avoid large crowds or poorly ventilated places, and wash your hands often. We're also encouraging employers to ensure they have adequate staffing contingency plans in place and consider reassessing more robust telecommuting options when able, especially in the midst of a surge. I'm now going to turn it over to Julia Peak to discuss some testing.
Perfect. Again, Julia Peak for the record. I serve as one of the deputy administrators here at the division and have been working for with the testing issues since the beginning of the pandemic with our team. Testing certainly right now does have a lot of attention just because the supply is low and the demand is so high. But I just wanted to highlight some of the things both for you and for our residents to understand that there's not one single option for testing, and we're trying to increase it across the 4 buckets that I put here. So community-based testing, this is what you've seen really throughout the pandemic, and we've had partners from our Nevada National Guard to federal partners that have come in and stood up federal sites to private vendors. And so these are the sites that you see at parks and potentially at schools and event centers and other things that help get testing to a large portion of the population.
This is typically a lab-based PCR where you get your collection and then it's sent out to a lab to be processed privately, or in some cases you could get a rapid test and then get the results that same day. This is a free resource often that's provided to the community. We've gotten a good amount of support just through direct funding and also from our federal partners, again, coming in and standing up these sites on our behalf. These certainly do have potential issues with appointments and folks showing up for appointments, but if we don't have an appointment system, then it does cause potentially waits to get that testing and could have traffic issues and other issues in that regard. But it is meant to allow people to have a single or multiple sites in their community to know that they can go and get tested for free at those sites. So we continue to stand those up. We have both privately funded community-based testing through state and local dollars, but then also we have some sites in Las Vegas that are supported through another project that our federal partners supply for surge testing. Probably one of the biggest new discussions is at-home testing. This really wasn't used in Nevada early on, I would say, but now is such a convenient way to test your family, and it does have nuances, and it's a matter of educating folks what those are. There are a few things that I'd like to highlight just for Nevadans as they figure out how they would like to get their at-home test kits. As you're aware, the federal government has really 2 projects related to this. The first one started just a couple of days ago where you can request based on your address 4 kits be sent to you. I did it myself, relatively easy. And I'll just note that we are aware of some challenges related to the program, and we've shared that with our federal partners, some challenges specifically in our rural communities or for those individuals that live in apartment complexes. So we shared that with the feds and they're working through that. But again, not the only program that's available to you. Another one is related to ensuring that private insurance covers COVID-19 at-home test kits through a pharmacy. And you're allowed up to 8 kits per month, depending on how many people you have on your plan. So that again is a supply challenge for our pharmacies, but certainly something that could make testing availability much more privatized in the future. And probably the project that I'm most excited about is the at-home test kit program that we're doing here in Nevada. We do have about 90 community-based partners that are going to be getting kits directly shipped to them. Little over 500,000 kits will go out hopefully the last week in January, and we'll be able to provide those kits to residents through our community-based partners to make sure that they have accessibility and have them at home if they do or a family member becomes symptomatic. The next thing is targeted testing. We presented to many of you in front of the Interim Finance Committee just talking about the federal grants we have. Some I would just like to focus on congregate settings. They focus on schools. We had a large epidemiology and laboratory capacity grant that's really focused entirely on our school-based setting to keep kids in school. We've also had funding for general community-based testing, as well as testing in our skilled nursing facilities and other healthcare facilities that are potentially a high risk. The last thing is private testing, and this is really hopefully the future of testing. And as we enter an endemic stage, just being able to test privately through your insurance, or again, if you choose to do the at-home test kits, that you could get that through your insurance. I'll just say early on, some private companies in Nevada, for example, some of our large gaming institutions set up testing for their employees, and we really learned a lot about what they did. We also, for state of Nevada employees, and I believe Legislative Council Bureau employees, had a similar policy where we set up vaccine or testing programs. And so folks would get weekly testing if they weren't vaccinated. And so that was something that the state of Nevada as an employer set up. And then we provided testing to meet that demand. That's going to be moving for us to our Nevada Public Employees Benefits Program. And they're looking to launch that testing soon. There's also a great deal of testing, I would say, around travel. And so that should really be something that folks are able to access privately, as opposed to using a community-based testing location or other testing modalities that are targeted really for people who are symptomatic or part of the targeted testing high-risk groups. So that kind of summarizes testing, certainly many nuances within that and opportunities for growth during the surge, but happy to take questions on this or anything we presented. Thank you.
Thank you so much for the presentation. And I also want to extend our gratitude to your office for all of the work that you've been doing during the pandemic, but particularly during this spike that has impacted so many of us. I don't know anybody at this point who has not come across, or at least had one family member come across this particular variant despite their vaccination. Although the symptoms do seem to be much, much less on my vaccinated friends, which is, we can attribute to those vaccines working well. I did want to just pitch out here for those who are watching that those COVID tests, those at-home tests you can order online, they're super easy to get. I ordered them for my family, although we have 5 of us, so that's one of the things that's not super functional about them. We could only get 4 at my house, but I was able to scrounge up an extra one from another family that had ordered them that was not taking or wouldn't need all 4 themselves, but that can be found at covidtests.gov. And I also found it at the USPS website. I don't remember what that one is off the top of my head. Let's see. Also wanted to just put out there that our school cases are impacting so many of us. You're not alone out there if you are stressed out about kids being home again. We have one who's been at home almost exclusively since a week before Christmas because she caught a cold and couldn't go into school for that week. And then we had break, and now we are in exclusion because of so many cases in her school. So we really feel for you and for our community members who are impacted by this. Just remember, you're not alone. If you need resources and help, please reach out. We, as your legislators, are able to help you find resources if you need them, but you're not alone out there. We have some questions lined up. Just so folks know the lineup I have Assemblywoman Titus, Assemblyman Hafen, Assemblyman Ornlicker, and Vice Chair Doniate in the queue for questions. I'm going to go ahead and start with Assemblywoman Titus.
Thank you, Madam Chairwoman, for the ability to ask questions. And again, I too want to thank the presenters, all of those involved with this COVID crisis that we now all agree is endemic as opposed to a pandemic. So it's not going to go away. We're going to have to live with this. And for those who don't already know, my family was touched by this crisis more than me just being the county health officer here. But my brother-in-law, who was just 56 years old, died December 28th of COVID. No comorbid conditions. And I've said this before, he was not vaccinated, but did not seek care either until it was too late. So I don't know of a family that hasn't been touched in this state. Having said that, however, I have some questions regarding the testing. And one of my concerns is, as was mentioned in the presentation, the Omicron variant does move very quickly. Just for an example, the incubation period for Omicron is just 3 days, whereas the initial COVID that we first identified was 5 to 6 days. And then the next strain was 4 days. And then the Delta variant and the Alpha variant was about 4 days also. So now we're down to 3 days in transmission. So it does spread like wildfire. The question I have is regarding the different variants. We know that the Omicron does not seem to be as, although it's more infectious, it doesn't seem to be, the symptoms are not serious as much. And we see that the death rate is staying pretty much plateaued. Are we doing the sub-testing? These rapid tests do not identify whether you have the Delta variant or whether you have Omicron or what do you have. And so who is doing that test? Are we still trying to do subsets so we know if Delta is even out there anymore? I know they do on a national level these variants, because these are just 4 of the variants that we've heard about. There are many other variants that we are watching. So tell me what the state is doing to identify the different variants.
Yeah, happy to do that. Julia Peak for the record, and I'll turn it over to Melissa if she has anything to add on that as well. We certainly are continuing to do review of what variants we find in the community. We do it through a number of different processes. One of the most interesting things that's occurred as a result of COVID is using wastewater surveillance as a mechanism to understand what variant is circulating in our community. So we have several sites actually in Nevada who are doing that review and providing that information up to us.
We also still do have a great deal of testing at our public health laboratories, both the Nevada State Public Health Laboratory and the Southern Nevada Public Health Laboratory. I'll just note that the Nevada State Public Health Laboratory just launched a new website that really shows you what they're finding in their specimens. Also, for some of these other testing modalities, for example, the one that we use for schools most often is through a partnership with Perkin Elmer and Keller Labs. They do about 10% of the variant testing on those samples. So we do still have a great deal of testing and review related to understanding what's circulating, and that does have an impact on therapeutics as well, and what will work and won't work, and that's very important for certain cases. So the group is aware of these at-home test kits. It's really something you do privately within your own home, and that's not reported to public health. So that's not information. For example, you don't bring your at-home test kit in and we somehow are able to detect what kind of variant you have. You would need to go for additional testing, and then a specimen like the PCR would be sent to, again, the state public health lab to do that testing. But it is a layered approach to understanding what the variant is. Again, the wastewater, and I would say utilizing our public health laboratories has been the biggest tool in understanding that. Melissa, anything to add?
Yeah, I would just add that the lineage and variant surveillance efforts that go on are really just surveillance to let us know what's circulating in our community and at what proportion. Not every laboratory-based molecular test goes on to have sequencing performed. Julia referenced the website that Nevada State Public Health Lab has launched. It really is amazing if you haven't taken a look, but it does explain their process. They do have capacity to perform about 200 sequencing a day, and then they're tracking the variants through real time in their website. And right now they're showing about 98% as Omicron in Nevada.
Great, thank you for that. And may I ask another question, Madam Chairwoman?
Yeah, before you do them,
you.
I just want to remind the committee that we also have our regional health authorities online if there are questions specific to those areas. Go ahead, Assemblywoman.
Thank you. So the Nevada Hospital Association released their report yesterday regarding the staffing issues, and I know we're going to talk about that probably on another agenda item. But they also made mention that 43% of the hospitalized patients are not vaccinated. And so the reason for the question on the Omicron and the variants is that as we move through this process, hopefully we don't see a continuing increase in this percent of unvaccinated. I mean, again, 43% of the people hospitalized have been vaccinated. So to say that it's just related to the non-vaccinated, it's just not accurate. And again, we'll see. We'd be curious to see if that number starts creeping up as more, resistance or some of these things are not effective against these viruses or these mutations of these viruses. My question is, are we looking at? And I also read a study just yesterday from Israel that getting another dose of the vaccine, say even a fourth dose, didn't seem to help at all with the Omicron variant or any of these variants. So, are we looking at anything in the pipeline to perhaps increase the resistance or to help with some of that, some of these preventive measures? Or is the state reaching out for any of these antivirals that we're taking? I'm concerned because, as Julia knows, I'm concerned that we put $19.6 million from the American Rescue Plan Act at IFC to the monoclonal antibody treatment, but now we're finding out that Omicron is probably not sensitive to monoclonal antibody treatment that's currently out there. So are we doing anything else that to kind of preemptively anticipate that we'll have less sensitivity with our vaccines?
Yeah, Julia Peak for the record. I'll go ahead and start, and I don't know if Chris, if you have anything to add once I'm done. One of the things, Dr. Titus, that I just say is that the Nevada Hospital Association, we of course review that data really closely as well. And one of our follow-up questions was, how many vaccines have these folks had? Is it 1? Is it 2? Is it boosted? What's that look like? And they don't collect that level of detail. So even though we say 43% are vaccinated, that could be a single dose or an incomplete dose. So as Melissa noted earlier, the full set of vaccinations that are available to you based on your age and risks and other things, we encourage folks to get that vaccination. Again, it does reduce the severity. Okay, related to I would say then what the pharmaceutical companies are doing. There's been some that have been looking at specifically boosters.
or vaccinations just for Omicron, but as you know, the variants change so quickly. Also looking at the number of boosters and all those things. So our teams watch that as well. CDC and ACIP also watch those and provide recommendations for us. But I do, we'll cover it a little bit in our next presentation as well. But we really in public health look at the full spectrum of services that we can be providing, from, again, vaccination for primary prevention to secondary prevention, disease investigation. And then the therapeutics, as you mentioned, is a core part of the response that we have to consider. And again, thank you on record for IFC approving that funding for us for therapeutics. We did ask for it broadly, not just for monoclonal antibodies, because we don't know what will happen. First of all, with the variants, but also what our pharmaceutical partners are coming up with in real time. And so there appears to be now one monoclonal antibody treatment that's effective against Omicron, but the supply is very low. And so Nevada gets an allocation, and we're trying to figure out how to best use our funding to direct those most at risk for severe disease to get that specific treatment. But that said, we're also looking in that in combination with the oral antivirals that you mentioned. We are getting those at an allocation. Again, our federal partners are supplying that to our Board of Pharmacy, and then we look at cases, ability to actually distribute and use within your community. And so we've been distributing to our skilled nursing facilities, for example, hospitals. We're going to be looking at distributing through some of our public health programs, like the Southern Nevada Health District as part of their pharmacy program. So we're looking at how to get those out. Again, it's a supply issue in this case, and supply will just go up. The other thing that we're seeing is that, again, pharmaceutical companies are coming out with new possible treatments regularly. And so we're watching that closely, potentially, you know, an IV antiviral coming out. So as those become available, we want to make sure that we use that $19 million to set those resources up in the community so we can quickly triage people to whatever of that menu is most appropriate for them based on their risk and accessibility and other things. We are certainly happy to provide updates on how we're distributing that money, as you are well due, and to assist you in helping navigate for your residents how they access that service, because timely treatment, especially for the oral antivirals, is very, very imperative as we look at actually the efficacy of those therapeutics.
Thank you. So did I hear you say, so what I'm hearing is that the state of Nevada and the federal government are controlling these antivirals that are being developed, and that the provider or physician has to then get permission from the state to then prescribe these based on what the state sets up as a criteria, and not the provider deciding that that's what the patient needs?
Julia Peak for the record, and I certainly have Dave Least, I think, stayed on as well if there are these questions. So the federal government does control what supply we have. We certainly are vocal about trying to get more of that allocation, but they do control where that goes into which state. Once it comes to us, we're providing that as we can to those who request it. The real issue has come with just the supply constraints. As far as a physician prescribing it, that's certainly allowable, and we have provided the pharmacies that are going to carry it. And I don't know if you'd like Dave to speak to that, or I could follow up with a list of those different entities that have it in stock.
I think we're going to, it's a long agenda, as Chair Peters has pointed out, and I'd love for you to perhaps follow up with how a provider can get access to that. Do they have to have a special training permission? It's a concern, obviously in my field, but I think for the public in general, that they may not have access without government permission. So I think a follow-up to the committee would be helpful. And thank you for your time. And again, thank all of you on that have presented today for all the efforts you're doing. I know these are tough questions, tough times. So thank you.
And Chair, this is Kyra Morgan. Is it okay if I step in and just elaborate a little bit related to the 43% of hospitalizations that are vaccinated? I did just want to reference, Dr. Titus, I know you're probably well versed in this, but in case maybe some people are still listening to public comment, or others might benefit, I did want to just elaborate on Julia's sentiment around not understanding if those individuals have received their booster. There is preliminary data coming primarily out of the UK. There was an article that was recently published in The Lancet that indicated that vaccination without a booster 25 weeks after your second dose can reduce efficacy down to about 10% protection. And so it is really important right now to differentiate. I know the CDC has not changed their definition for fully vaccinated, but it is really important to understand the difference that a booster shot can have on that vaccination series. So I just wanted to use that as an opportunity to really emphasize that for maybe other people who might be listening.
Thank you so much for the responses to those questions. And Assemblywoman Titus is correct. We would love to hear more from you about how this is rolling out and what the limitations are and successes are. So please continue to keep us in the loop on that. The next person I have in line for questions is Assemblyman Hafen.
Thank you, Madam Chair. And I'll try to keep this brief and just echo my colleagues' praise to all of you. Thank you for what you've been doing. And echo that we've all been touched by this with family and friends. And my question was in regards to the prison population. And I know you gave the data of tracking that, but do we have any information, or you could follow up later if possible, on the vaccines? Are we administering vaccines upon admittance? Obviously by their choice. I was just kind of curious on that.
Carissa Loper for the record. I can't speak to if they are vaccinating inmates upon admission, but we do work with the Nevada Department of Corrections to ensure that they have vaccines in stock at their facilities and that their pharmacists and medical staff can administer those to the inmates upon their request.
And if you could just ask them if they are doing that and follow up. And then also, I know it's slightly off topic, but I'd be curious to know if they're also doing that with hepatitis and other vaccines. If you could just ask Department of Corrections and provide that information, I'd greatly appreciate that. Thank you so much. And thank you, Madam Chair.
Thank you. I think we can also have staff potentially reach out to Department of Corrections on that issue as well. The next I actually want to go back. We have a Zoom chat, but I don't believe it is a part of the record. And Kevin Dick with Washoe County made a comment on this chat that I'd like for him to make on the record on the Zoom video if he's available. Mr. Dick, are you available to talk a little bit about that COVID-19 hospitalizations comment? Please go ahead.
Yes, thank you, Chair Peters. My comment was that the Hospital Association went there indicating that they have 43% of the COVID-19 cases being vaccinated that are hospitalized. What we're finding in Nevada and nationally there are a number of people that are showing up at the hospitals for other medical needs that they have. And then the hospitals are testing them and finding that they have COVID-19. So they may not be at the hospital because of a severe case of COVID-19. They're there because they have other medical needs, and then they're found to have COVID-19. So they have a mild case of COVID-19, but they have other medical issues. This doesn't reduce greatly the burden on the hospital because they still have to treat that patient as one has an infectious disease and put them in their infectious disease ward to try to prevent the transmission. But I think that if you just look at that statistic and the 43% vaccinated, I don't think it reflects the rate of severe cases that are vaccinated that are the vast majority of the severe cases are unvaccinated. Thank you.
Thank you. Senator Hardy has a question related to percentage of asymptomatic COVID, I believe. Senator Hardy, do you want to ask that while we have Mr. Dick on the line?
Sure. So we know that there are some that are asymptomatic. So when they come to the hospital and they get I'll call it just a screening test, and they're positive, there is obviously percentage of people who are asymptomatic in the community. And even though they haven't been tested, even though they don't know that they have it, they're still capable of passing it on to somebody else. So do we have that kind of statistic about the percentage of asymptomatic COVID people, not patients, but people right now? And, you know, the theory is the more we test, the more we find, we may find more people that didn't know they were positive, but they're certainly able to pass that on to somebody else. Hence the challenge with testing, giving us sometimes a false sense of security if we don't test, or a complication of testing more people. If you could elaborate on that, appreciate it.
Yeah, thank you, Senator Hardy. And really, that's $1 million question. We really don't know how many people have COVID-19 because we do have asymptomatic cases. And with the percentage of people that we have now that are getting vaccinated and the protections that the vaccine does afford, many vaccinated people may end up having an asymptomatic case because of that protection, but they're not seeking testing because they don't have any symptoms. And right now, we have an extremely high demand for testing. And that's driven, I think, primarily by people that are symptomatic now with the Omicron, or they have, with the big increase we've seen in Omicron, or they've been a close contact of a case. And so we're finding here in Washoe County, 35% or so of cases over the last 7 days are positive for COVID-19. So that tells us there's just a lot of it out there in the community. And we don't have a way of ascertaining how much is really out there because of those asymptomatic cases. That's why it's so important that people practice precautions. The masking, wearing a N95 if you can, a KN95 are more effective than the cloth masks that most of us have been using up until now with Omicron. Social distancing, trying to stay in your home while you can, while this tremendous wave is passing over us, and avoiding interactions with other people that you don't need to be engaged with. Those are the things we need to do to try to suppress the spread of the Omicron variant right now.
Madam Chair, if I may follow up.
Yes, go ahead. And I'm going to ask that that DPVH please consider responding as well. Let me know if you'd like to respond.
So, I read a lot, obviously, about this, and we talk about hand washing, and I'm not sure I've read a article about hand washing and how important it is, and I'm wondering if one of our major efforts to hand wash may not be as effective as we think it is, and sterilizing doorknobs, et cetera, and I'm not going to pick on anybody, but it's nigh impossible to not touch your mask at some point when you're wearing it, when you're out and around and with people. And so have we seen the study that shows that hand washing may or may not make a difference as much as we would like?
Well, thank you for the question, Senator Hardy, and I apologize. I don't think I identified myself for the record. I'm Kevin Dick, District Health Officer for the Washoe County Health District, and appreciate you bringing up hand washing. I should have mentioned that, and the reason I should have is overall for infectious diseases, it's very important that we do hand washing to prevent us getting sick from all kinds of different diseases with touching our face, our mouth, food that we're eating, those kinds of things. I have not seen a study recently with Omicron or COVID-19 in regards to hand washing. And early in the pandemic, we were heavily emphasizing hand washing, cleaning high touch surfaces, et cetera. I believe that that's still important, that we need to be promoting. However, I think our understanding of COVID-19 has evolved, and we we are more aware that it is incredibly transmissible through airborne transmission. And that's why ventilation, masks, distancing, number of people within a space are all important to try to control the spread through that airborne transmission.
Thank you.
Thank you. Chair Peters, I believe you're muted.
I was talking to myself. I was asking if Ms. Pete Bullock had any response as the state epidemiologist to the hand washing comment. I know with 3 kids, it's incredibly important for us still, despite what it may impact for COVID. We are still catching colds from just general touch surfaces that the kids are exposed to. But if you, Ms. Pete Bullock, if you would like to respond, please go ahead.
Yes, absolutely. Melissa Peak Bullock for the record. And I absolutely agree with the responses made by Kevin Dick previously. We don't have recent studies out on hand washing with Omicron and COVID-19. But again, it's extremely important to reduce the spread of infectious disease across the board, especially when you look at settings, as you had just mentioned, Chair, in daycares, preschools, the school setting. There's a lot of high touch surface areas, a lot of, touching the mouth, the nose, touching other objects, touching your friends, that sort of thing. It's also extremely important when you look at food safety. So even in your own home, so washing your hands, after you cough, sneeze, use the bathroom before you're preparing food for other people, because that is also a great vehicle for the spread of disease as well. So I just want to reiterate that hand washing is a great prevention tool to be implemented to help with all infectious diseases.
Thank you so much. I unmuted myself this time. Excuse me, Assemblyman Ornlicker, I have you next on the list if you would like to go ahead with your comments or questions.
Thank you, Chair. I have a question about the statistic on completed vaccination. As Kyra mentioned, that there are different definitions out there, what it means to be completely or fully vaccinated. So I'm just curious which definition you're using. If somebody's had 2 Moderna or Pfizer shots, is eligible for a booster, hasn't had a booster yet, do you still count them as completed? And if you do, is there a separate statistic that would tell us the number of people who are not really fully vaccinated because they haven't had a booster they're eligible for?
Yeah, this is Kyra Morgan for the record. Carissa, you probably have more details than I do, so chime in if I get this wrong. When we're talking about fully vaccinated currently, we are not including booster or follow-up doses. I think that is because our national leaders haven't changed that definition, so we're still anchoring to what the CDC is using. We do on our dashboard have a separate measure which indicates follow-up doses. So that's not just your booster for your average healthy adult who's 25 weeks out, but it's also individuals who are immune compromised or eligible for another dose as part of their vaccination series. And so that is listed currently for Nevada as 609,000 boosters or follow-up doses have been administered.
Thank you.
I have one more person on my queue for comment, and then we're going to move on to the next agenda item. Doniante, please go ahead.
Thank you so much, Chair Peters, and of course, thank you to the DHHS staff for your presentation. Your work is definitely noticed, and we greatly appreciate you. I just have 2 quick questions. The first one lies with the recent announcement by the federal government with the shipment of free N95 masks. Can you detail the state's strategy on how we're going to implement that change and that shipment and how we're going to distribute it throughout the state? And then my second question is more about vaccine uptake. Can you talk about some of the groups that we're seeing that might share vaccine hesitancy and how we're closing the gaps for folks that either face language barriers or other types of barriers, and of course, who are vaccine hesitant? Like, what are we doing in terms of that work? Thank you so much.
Perfect. Thank you. Julia Peak for the record. I'll go ahead and start out with the PPE, specifically the N95 mask.
So we're still figuring out locally how we're going to implement that. But I'll just say one of the things that I think Nevada did exceptionally well is to double our stockpile of PPE prior to this surge. So we do have that stockpiled. We're looking to fill a number of requests from our schools because they want to upgrade again to make sure they do have the N95 or the KN95. So we're working through that request, at least in that high risk setting. Our healthcare providers have always been able to ask for that supply. So again, just touching base with them, making sure that in those settings where there is potential high risk spread, that they do have even our state supply. But again, if the federal partners are sending additional supplies, we will certainly use that as well. And then to make sure that there is availability of supply for KN95s or N95s for our general public. So we could look at a very similar methodology to how we're doing the at-home test kit distribution, again, over 90 community partners statewide. And so we can certainly provide updates as we delineate how that's going to go. But we do have a really healthy supply of PPE in our state, luckily, because of prior planning. I'll go ahead and turn over the vaccine efforts to Carissa Loper to handle.
Thanks, Julia. Carissa Loper for the record. Thank you for the question, Senator. So we are working with Immunize Nevada, Make the Road Nevada, a number of other groups through Immunize Nevada, who is working with those local partners on the ground to reach Hispanic populations, African-American populations, and younger adults, so 18, say, to 29. That's where we're seeing less uptake of the vaccine. So translates to more hesitancy, though we don't always know specific reasons why, but we'll work with the trusted messengers within their communities, faith-based leaders, other community leaders to help spread the positive vaccine confidence message, make sure their questions are answered, and that they can speak with a healthcare professional if they would like to about their concerns.
Thank you so much. I am going to go ahead and move us on to the next agenda item now so we can keep things moving forward. But in the same vein, we're going to be talking about an overview of public health lessons learned from the COVID-19 pandemic and the path forward. I'm really looking forward to what we're looking at moving forward and how to reduce potential future pandemic impacts to our communities. Please go ahead, Department of Public and Behavioral Health, looks like you are taking lead here.
Good morning, Melissa Peak-Bullock, State Epidemiologist in the Division of Public and Behavioral Health. For the record, once again, I am joined today by Julia Peak, Deputy Administrator within the division, Carissa Loper, Health Bureau Chief in the division, and Megan Komlosley, Associate Director of the Center of Public Health Excellence, Larson's Institute for UNR. Today, we're going to provide a brief history of public health, the core public health programs, and their support to the pandemic response, and opportunities to improve public health services in Nevada. So what is public health and why did we not hear about it until COVID-19? While the terminology may be new to many, the concepts and applications are far from novel. Public health is a broad term, but it encompasses targeted focuses such as prevention of disease and death. This can be related to infectious disease, injury, and chronic disease. Another major focus is on targeted intervention or prevention measures for certain populations. This is largely tied to available funding sources, which is illustrated through our maternal and child health program. Another term that was not widely known before the pandemic was epidemiology. While there are many subsets of epidemiology, infectious disease epidemiology has been a foundation throughout the pandemic response. Infectious disease epidemiology is a practical, science-based practice that is concerned with minimizing the impact of infectious agents on the health of the public. This is a population-based science that studies patterns of disease incidence and uses the disease-specific data to identify interventions in order to minimize the risk of transmission and severe outcomes. Epidemiologists take into account many factors, such as the mode of transmission, the incubation period, the window of transmissibility, also known as the infectious period, seasonality, and the stability of the infectious agents. Common terms used in epidemiology are also vital components, and those include biostatistics, case investigation, contact tracing, disease transmission, the epidemic curve, vaccination, and treatment. Next slide, please. I'm going to provide just a brief history of public health. During the past 150 years, two factors have shaped the modern public health system. The first is the growth of scientific knowledge about sources and means of controlling disease. And the second is the growth of public acceptance of disease control as both a possibility and as a public responsibility. In earlier centuries, while little was known about causes of disease, society tended to regard illness with a degree of resignation, and little action was taken. As understanding of sources of infections and means of controlling disease became more refined, more effective interventions against health threats were developed, and public organizations were formed to employ newly discovered interventions. As scientific knowledge grew, public authorities expanded to take on new tasks. This included sanitations, immunization, regulation, health education, and personal health care. Before the 18th century, epidemics such as the plague, cholera, and smallpox were often thought of as signs of poor moral or spiritual conditions, and few public health efforts had occurred. However, in the late 17th century, public health authorities adopted and enforced isolation and quarantine measures as a result of the plague. In the 18th century, isolation of the ill and quarantine of the exposed became common measures to contain infectious diseases, especially considering smallpox. The 19th century. This marked a great advance in public health, the Great Sanitary Awakening. This was the identification of filth as both a cause of disease and a vehicle of transmission. The resulting embrace of cleanliness was a central component of the 19th century social reform. Sanitation changed the way society thought about health, and protecting health became accepted as a public responsibility. Although disease control was still focused on epidemics, the manner of controlling shifted from isolation and quarantine to cleaning up and improving common environments. Disease control shifted from reacting to outbreaks into deploying prevention measures. At the close of the 19th century, major advances in public health took place, which were brought about by rapid advances in scientific knowledge about causes and prevention of numerous diseases. The discovery of bacteriologic agents such as anthrax, tuberculosis, diphtheria, typhoid, and yellow fever. This led to advances in immunizations and water purification efforts to control the spread of disease. The germ theory of disease provided a sound scientific basis for public health. The means of controlling infectious disease changed dramatically. Laboratory research was identifying exact causes and specific strategies for prevention. Science also revealed that both the environment and people could be the agents of disease. The scientific advances that were made led to the development of state and local health departments and laboratories, which provided the opportunity to continue scientific growth. A major focus was improving sanitation through treatment and control of bacteria in water. In 1891, the presence of fecal bacteria in water was first identified as the cause of typhoid fever and resulted in the first sewage treatment techniques. Much of the history I've just discussed was focused on public health issues related to infectious disease, because at that time, people were dying at young ages related to uncontrolled transmission of diseases. Because of the advances made over time in public health, people are now able to live longer and live long enough to face the consequences of chronic disease. Public health has expanded greatly throughout the course of history and now encompasses prevention efforts related to infectious disease, chronic disease, and injury prevention, among many other areas. Public health has evolved over time, and it continues to evolve, as has been highlighted throughout the COVID-19 pandemic. Every day, public health professionals work in the background to promote and protect the health of people and communities. While a doctor treats people who are sick, those of us in public health try to prevent people from getting sick or injured in the first place. Examples of this are vaccinations to prevent the spread of disease, education on the risks of tobacco and alcohol. Public health was a major voice to promote smoke-free indoor air laws and seatbelt safety laws. Public health helped to set food and safety water standards, develop food school nutrition programs, and we track and respond to disease outbreaks. Investing in public health resources is vitally important. Public health saves money, it improves our quality of life, it helps our children thrive, and it reduces human suffering. I'm now going to turn it over to Julia Peak.
Julia Peak, for the record. one of the questions that we get most often in public health is, what is the difference between public health and healthcare or clinical services? And it does cause confusion. To see what we focus on in public health is, as Melissa had noted, it really is our eyes are on community health, population health, and how we can impact change over time, ideally through prevention and risk reduction. A focus for us is really meeting people where they are at on the spectrum of prevention. We also have a larger scope, as was presented earlier: clean air, safe food, reduction of disease and infection, ultimately, so everyone has the ability to live the longest and healthiest life possible. A lot of our work is looking at disparities and risks in certain groups, both geographically and demographically. They say that your zip code could have more impact on your health status and ability, again, to live a long and healthy life, as opposed to your genetic code. So geography is a huge thing that we look at. We also have an example on here for clinical services, and this is much more what people are aware of. It is you going to your doctor or dentist and looking at plans and interventions for individual health. It's an individual assessment of risk and strategies to address the health status of that individual. To give you an example, just looking at asthma, if you go to your doctor and you have issues with breathing, you're going to just look at symptoms, you're going to do tests, and you're going to get some sort of medication potentially prescribed if you do have an asthma attack, so that your individual health is sustained. When we look at asthma from a population health perspective, we say one of the studies we looked at was actually asthma admissions to hospitals, and is there a geographic or demographic issue that's potentially causing this, and where and how can public health intervene? That's just one example, but it is looking at the same condition just through a different lens. Next slide, please. This is one of the best things that I've seen that helps you understand where in public health we can make an intervention that affects the most people, but also different strategies. Just, again, for this presentation, we're going to look at COVID, and I just want to give a couple of examples. So the individual, again, has so much power in how COVID is transmitted and prevented. With the individual, we've done a lot with information sharing, direct outreach to individuals through our community-based organizations, through media and other outreach opportunities. Looking at the specific risk for that individual and addressing any questions they have potentially related to vaccination, or during the conversations for isolation and quarantine, if they're a case or a contact, we talk to them about what their potential risks are. We make a change individually every time we do that. If we look organizationally, one of the things that I'd like to highlight is just what we did for state employee testing, where we looked at a vaccination or test policy. That's something we were able to do and increase vaccination rates greatly, and also identify cases of COVID that may not have been identified among our employees, so we can ensure that it doesn't spread at the work site. That's something we've done, and other private employers have done as well. When we look at policy, some of the things that we've done are emergency regulations or temporary regulations, looking at mandates for vaccinations. That is where you can come in and make the most change in the shortest period of time. As was mentioned earlier, some of our seatbelt laws, smoking laws, and other things are really good examples of how public health policy has truly impacted people's ability in our communities to live long and healthy lives. This next slide is really pivotal. I'm not going to spend a huge amount of time on it, but it's great to understand the scope of public health. And our partners have developed this 10 essential public health services. It's something we look at to ensure that our health department is operating from a place of equity, but also that we're meeting every single place on this essential public health services, and that we're providing the best opportunity for our residents through our services. Many of these programs have been highlighted during the pandemic, so the public and you all have seen how we've addressed very specific things, but there's certainly opportunity to assess and plan that kind of portion of the circle to make sure that for the next pandemic or the next health issue that we're prepared. And Ms. Kamwasi is going to talk later on about some very strategic things we're doing to make sure that we are providing the best public health services in Nevada, and that we continue to have a quality improvement process. Already mentioned this a little bit, but we really have a structural foundation in levels of prevention, meeting people where they're at, as I mentioned earlier. Primary prevention is focused on ensuring that there's the littlest risk possible, hopefully to eliminate the spread of a disease or a condition, or to reduce the risk. And that's been a huge part of our COVID response. You saw this in our stay-at-home orders initially, and then you've also seen this with vaccination efforts to ensure that people reduce their risk of contracting the disease. Secondary prevention is what you've seen for COVID related to our testing and disease investigation. Part of the testing is ensuring that public health gets results of those labs and we can follow up with individuals, especially those in really target populations, schools, skilled nursing facilities, correctional settings, so that we can intervene and stop that spread as much as possible. This is also really true for chronic disease as well. If we can get screening programs for cancer to help people who might otherwise not have been able to identify that they had cancer, identify it early, and then hopefully refer for treatment. Tertiary prevention occurs when the person already has severe illness, and it's ensuring that we have therapeutics in place and they have access to those services. Talked about it a little bit earlier in our presentation, but for COVID, it's making sure that we have as much supply in Nevada as we are allowed, continuing to advocate for more, but then ensuring that it's accessible to whomever is most at risk for severe disease or death. I'm going to transition to talk about some of our core public health programs. I'm going to use the lens of COVID-19, but I'm also going to highlight some of the other things that these teams have done. This is not an exhaustive list. Public health is a huge agency, and so I'm just going to highlight a few. The first, I would say, as it related to the COVID-19 response, was our planning and preparedness programs. They focus on emergency response and logistics. They have also done planning exercises locally well prior to the pandemic, looking at pandemic flu planning and how we would intervene. Also have taken great effort as it relates to environmental issues and how we can help people navigate services if there's a wildfire or a flood or whatever that might look like. Also, they have a regular eye on healthcare capacity, getting information on ER bed status and helping us understand what that looks like prior to COVID and with COVID. They also have worked hard on crisis standards of care that have, again, looked at healthcare capacity, healthcare access. They've been a pivotal liaison between our public health programs and emergency management. I'll just say, without them being there as the liaison, it would have been a much rockier implementation, because our emergency management National Guard have been the right hand of the public health response. So just want to acknowledge the team for doing that. Also, the resource management and logistics, as I said, we have doubled the stockpile of PPE in our state. That's a logistics challenge, and also ensuring that it gets to the folks who need it. This has been necessary as well for testing and other resources that we've had to distribute out to the community. And I do just want to highlight here also our community health nurses. They were providing emergency planning and services well prior to COVID, and they also now are continuing to provide vaccinations, STD testing, family planning, and did so during the pandemic as well for their residents. Talked a lot about epidemiology and laboratory capacity. I'll just say that there's great opportunity here to improve testing in the short term, and I talked about that, but also laboratory services. One of the biggest challenges we had was couriering specimens from rural Nevada to the state public health lab, and some of the things that we're doing in that regard is ensuring that we have satellite locations. The most ready one will be in Churchill County, so that they can service on behalf of the state public health lab a number of our rural communities. Also, disease investigation, and what I'll say for disease investigation, in addition to what we've provided, is we had such a small workforce to do all diseases prior to COVID. We still have a very small workforce for epidemiology, even with the COVID funding. And it has to do with pipeline efforts and finding and retaining people who have skills in epidemiology. Again, some of the efforts we're going to talk about for opportunities will highlight this. With COVID, we had to quickly redirect our disease investigators who were potentially investigating syphilis, which Nevada has the highest rates of syphilis in the nation, but the fire, for lack of a better word, was COVID. And so we've had to redirect those resources. What that means for public health is that when COVID becomes less time intensive, we are going to have so many other public health diseases and conditions that have spread in our communities that require a great deal of attention and funding and resources to make sure that we're addressing those as well, and that any pause that occurred, we can recover from. We were having to, prior to COVID, look at which STDs, for example, we would investigate. nationally, there's the highest rates of chlamydia that have been seen in so long, and states and counties are not able to investigate chlamydia, though undiagnosed chlamydia can cause infertility. So again, such an important public health project, but we just can't staff it with the categorical funding that we have from our federal partners. We also, one of the challenges in being so dependent on our federal partners to provide funding for public health is that there's delays. They certainly moved faster than normal under the COVID response to get funding to states, and then states to get it out to our local public health departments. But by the time we actually got funding for workforce and IT investments and other things, we were well into the pandemic. And so we were forcing our epidemiologists to not only recruit and train and supervise these staff, but they had to respond directly themselves to cases that were coming in through the floodgates. So that delay in ensuring that we had the funding to quickly stand up services was really, really challenging. Environmental health, we did talk about this a little bit early on. They are such a strong part of our public health response. They helped us early with COVID to look at infection control and cleaning, even sending them into skilled nursing facilities initially to figure out where risk could potentially be in the facilities so we could limit spread. They've also done a great deal of work to look at events. Nevada just relies so heavily on special events, and having visitors and ensuring that our restaurants and our events are as safe as possible has really been on the backs of our environmental health professionals. We also have done a lot with climate change and air quality and temperature issues. With COVID, we had to, and the wildfires, for example, we had to close schools just because the circulation that was necessary to prevent the spread of COVID within the classroom, it needed to occur with the ventilation, and we just couldn't with the air quality outside. And that's something with climate change that we'll just be having to deal with much more. Also, with COVID, when the temperatures were hot outside, people would congregate indoors and we'd see transmission indoors again. The last thing, not specifically related to COVID, but a lot of work is done on looking at, do people have access to safe and close outdoor recreation? Can we change the landscape of our communities to ensure that there's walking paths and safe parks and other things in our communities? So we encourage people to go outdoor and recreate and increase their overall health and wellness. I'm just going to give one example of this, and Melissa is certainly better to talk to this than me, but I just want to explain how we were doing this well prior to COVID and give you an example of how in epidemiology we can track a source with our environmental health partners and really put an end to it. So within Washoe County, we had an E. coli 0157H7 bacterial infection, and we started seeing a number of cases come in Washoe County, and this is really important to address quickly because this bacteria can produce a toxin that can affect kidneys and cause kidney failure. So the teams in environmental health and epidemiology focused a good amount of attention on it initially. They were able to do the investigations of the cases coming in. So again, when that's reported to public health, the epidemiology teams follow up with the individual and figure out what their potential exposure was. And then based on similarities between those cases, we can figure out where the common source occurred. And so based on the investigation that this team did, it was linked to one source. And then environmental health specialists were able to go in and look at food samples sent to our public health laboratory. Again, a great resource to us in our public health response. Ultimately, we were able to identify the source of infection and completely stop further transmission. And then we worked with the facility to make sure that their safety standards were in place to prevent this from happening. I'll also note, just because we've talked about it in COVID, when community transmission is so incredibly high, it's really, really difficult for us to say that this was the single source of exposure, both just quantity, and an individual could have multiple locations where they could have potentially been exposed. So I know that's been a challenge for us to do, but also a challenge for the public as they try to assess locations of higher risk or lesser risk. That's been quite a challenge with COVID. Joseph, I think 2 slides. Okay, I just wanted to talk a little bit about analytics because you hear us talk about data a ton as it related to COVID, but I just want to say we look at data for everything. It's been inherent in the pandemic response to make sure that we are able to provide data quickly. And that's not only to be transparent, but to address any specific issues. That's been one of the most difficult parts of the public health response because public health data is often not timely, not overnight, or within a couple days. We take a year to make sure our HIV data is correct. We are several years behind in cancer data to make sure that's correct and accurate. And so turning over data in real time has been a logistic challenge and a great deal of work from an IT, a lab, and epi perspective. We use data beyond COVID to look at morbidity and mortality, as I said, both demographically and geographically, to figure out what is the specific issue causing a specific outcome. Sometimes it is risks of an individual, sometimes it's access to health services. And so we have to look at all of those things. The data also helps us benchmark where we are at for a certain issue, and so we can make measurable improvement in those areas. Nevada is so dependent on categorical funding, as I've already mentioned, that it also helps show us where there might be diseases or conditions that need additional attention and therefore funding. Healthcare licensure for the next slide, Joseph. This, I cannot not even begin to explain the burden that this group has taken on related to infection control, and then specifically laboratory licensing. This slide provides a summary of all the different types of licensing and quality assurance that we provide at the different types of facilities. I do just want to highlight what our childcare facilities have done. As Melissa noted, there's just been such a challenge just with children in general, with spread, and making sure that we provide infection control in those settings. But I do want to call out medical laboratory licensing. This small but mighty team has been able to bring on so many labs and also sites that do specimen collection and send out for results. The workload has increased exponentially, and they've also been following up on complaints that we get from the public related to those specimen collection sites or laboratory quality or other things. And it's just been such an under-resourced but pivotal part of the response. I'm now going to turn it over to Carissa Loper, who serves as our Bureau Chief for the Bureau of Child, Family, and Community Wellness. And she's going to go through some of the programs that are within her section.
Thanks, Julia. Good morning, committee members. Carissa Loper, Health Bureau Chief for the record. As you have heard, vaccines and immunization as a standard preventive practice are considered one of the top public health achievements of the past century and are credited with helping to lengthen life expectancy in the United States and globally. Vaccines help prevent some of the deadliest infectious diseases that still exist. Today, we hear a lot about the COVID vaccine, but the division's immunization program has always been working to ensure Nevada's population can access all recommended vaccines. Immunization program staff work with federal and local partners and Nevada's vaccine providers to order, distribute, and track publicly supplied vaccines. And ensure all vaccines administered in the state are recorded in our Nevada WebIZ immunization information system. We work with a variety of community partners to use local data and information down to the zip code level to improve activities and ensure vaccines are being distributed equitably. For example, as a result of the pandemic, the governor called on us to ensure the COVID vaccine was being distributed equitably, and we quickly worked with Immunize Nevada, our statewide nonprofit that works on promoting vaccines, and the Minority Health and Equity Coalition at the University of Nevada, Las Vegas, to develop the Nevada Vaccine Equity Collaborative. The collaborative has helped the state reach out to disparately impacted populations more effectively by engaging with trusted messengers such as local faith and community leaders. Next slide. The immunization program also works closely with our colleagues in the epidemiology office to track and respond to vaccine preventable disease outbreaks in the state. One example of this in action happened back in 2017 when we experienced a pertussis or whooping cough outbreak in rural Nevada, which spread into the school system. Following standard disease investigation activities, exposed contacts were identified and provided with treatment to help prevent them from developing whooping cough. Additionally, the immunization program was brought in to work with our local partners in the community to ensure they had enough vaccine to do targeted pertussis clinics. And we helped provide education and information to local providers, partners, and the public about pertussis disease and the vaccine. Ultimately, the outbreak was quelled due to these combined actions. Next slide. Public health is about prevention, as you've heard. It's about using data and research to understand behavior and find ways to encourage and influence health positive behaviors. To that end, the division's chronic disease prevention and health promotion program has always worked on tracking, understanding, and preventing chronic disease in Nevada. Tobacco cessation and control is something most of us have heard about and are familiar with, indoor clean air acts and such. But less publicized programs that are no less important include diabetes prevention programming, like the Diabetes Self-Management Education Program and the National Diabetes Prevention Program. We also run heart disease prevention programs like the Self-Monitoring Blood Pressure Program, working with local health providers, and we run a strong stroke prevention program. The division has been working with healthcare provider groups, federally qualified health centers, partners like Access to Healthcare Network, and many others to develop and deploy chronic disease prevention and management education and programming to Nevadans. In the context of the COVID-19 pandemic, we began to see early on that individuals with comorbidities like obesity, diabetes, heart disease, or who already had compromised lung health were and remain more likely to be infected if exposed, and much more likely to end up with symptomatic disease that results in the person being hospitalized or dying. This further drives home the importance of continuing and increasing efforts to help prevent chronic disease. We also saw COVID impacting some communities and groups more than others, resulting in both health and economic crises for the people who could least afford either. Across public health, we have renewed and invigorated our efforts to use local data and work with diverse community partners to ensure program resources are distributed equitably. We are working with partners now to deploy community health workers to underserved communities to provide education and information about testing and vaccine availability in those areas. Next slide, please. The division works with many partners and at many levels to ensure access to healthy food for Nevadans. Food access and nutrition is a concern for public health because of how closely what a person eats is tied to their health status, as the previous slide made clear. Not to mention the safe food practices Julia talked about with environmental health. Obesity, heart disease, and diabetes are all related to a person's eating habits and patterns, which are a direct result of the food they can access and their knowledge of nutrition. For example, the Nevada WIC program, or Women, Infants, and Children Nutrition Program, includes required office visits to assess a family's nutrition status and adjust their recommended food package if necessary. One challenge of the pandemic is it forced the WIC program and our local partners to adjust to virtual visits, making it difficult to provide a nutrition assessment, but not impossible. So we were still able to serve Nevadans at the end of the day. One success coming out of the pandemic related to WIC has been an enhanced benefit that is being provided to WIC participants through a federal government nationwide increase in benefits that allow them to buy more fruits and vegetables specifically. And that benefit is currently being funded through March 2022, and we're monitoring the uptake of that in our Nevada participants. Other efforts we focused on during the height of the pandemic response related to food access included launching prescription produce boxes to get fresh fruit and vegetables to patients who are food insecure and referred by a partnering provider because they have a diagnosis of hypertension, high cholesterol, and/or have had a cardiac event. And finally, we worked with multiple state and local agencies and partners to help food banks navigate the pandemic and best serve Nevada's most vulnerable and food secure individuals, including working with the Aging and Disability Services Division to serve older Nevadans. That's just a taste of what we've done during the pandemic and before to work with all of our partners and agencies across the state to protect food security, combat food insecurity, and ensure that populations can access safe and healthy foods. Next slide. I will wrap up my short section by touching on maternal and infant health. Pre-pandemic, the maternal, child, and adolescent health section worked across Nevada to build partnerships and provide resources and education to organizations serving mothers, babies, and families. This type of systems level coordinating, partnership building, and resource deployment and navigation represents core public health work, which is integral to reaching people with accurate and timely information during the pandemic through our trusted partners and sites such as Family Ties of Nevada and the Nevada Governor's Council on Developmental Disabilities. Maternal and child health staff have partnered with staff in the immunization section in the WIC program and the chronic disease prevention programs to ensure that accurate and timely information can reach pregnant people and families about those topics. Recently, in action, the MCH and immunization staff partnered to provide an educational webinar to parents wanting to know more about the COVID-19 vaccine for children ages 5 to 11 years.
They have also been working closely, those teams, to ensure children and youth with special healthcare needs are able to learn about and access the COVID-19 vaccines from their trusted providers. Finally, the Nevada Home Visiting Program includes home visits as a core activity. Our partner agencies and the families they serve worked together and with state and federal partners throughout the pandemic to adjust to changes in health and safety recommendations in real time. Despite the challenges we have all faced, enrolled Nevada families were successfully served and creative program ideas were implemented, like virtual group parties and eventual outdoor group events to keep the families connected and to provide social interaction for the children. Home visitors ensured that families were quickly connected to any resource they needed, especially during the shutdown periods when many people lost their job and suddenly needed housing or food assistance or help navigating unemployment insurance. Our home visitors were integral to helping people get information and access resources that they needed. Truly, the work of and need for public health has been illuminated during this pandemic. So now I will turn it over to Megan Komlossi from the University of Nevada, Reno Larson Institute to discuss opportunities to improve public health services in Nevada.
Thanks, Carissa, and good morning, Chair Peters and members of the committee. It's good to see you all again. My name is Megan Komlossi. I'm the Associate Director of the Center for Public Health Excellence within the Larson Institute at the University of Nevada, Reno. And just want to provide a brief recap before we jump into the opportunities. So what you've heard this morning so far is a brief history of how governmental efforts to keep the public healthy came to be, and how through scientific advances and constant evolution, they've come pretty far. You heard how what we call public health really involves efforts to keep communities healthy by looking at the big picture, at a wide range of factors that affect the health of the entire population, and then figuring out how to prevent or reduce the things that harm health and promote or improve the things that make people healthier. I think one of the toughest things to really wrap your head around when thinking about public health is that it involves so many things, and there are things that we don't necessarily associate with the term health. But hopefully this presentation has helped clarify the difference between the individual healthcare we seek at the doctor's office or in a hospital and how public health professionals work to keep entire communities healthy. The other critical thing to reiterate is that when public health activities are working, we don't necessarily know or hear about them. We take the accomplishments that you heard about, clean water, sewage systems, access to healthy food, so the accomplishments of public health for granted. Many of us may not have been familiar with the term public health prior to the COVID-19 pandemic, or we may never have even heard the term. It's something that happens in the background, and it's generally invisible, but it has a real impact on our daily lives, whether we realize it or not. However, in your role as state policymakers, it's critical that you understand what public health agencies and practitioners do, both in your communities and across the state. The health of your constituents depends on having strong public health systems that keep our communities safe and healthy during normal times, and that are well equipped and have the resources to respond to crises or emergencies when they happen. So on that note, we'll turn to current achievable opportunities to improve public health in Nevada. My team at the Center for Public Health Excellence is working closely with the Division of Public and Behavioral Health on a number of these initiatives, and I'm excited to discuss a few of them with you today. So I think it sounds like you're going to do a deep dive into all things public health as you get into the SB 209 study. So today I just want to provide a high-level overview of a few opportunities. These include pursuing local administration to improve and streamline public health services in rural and frontier counties, establishing academic health departments to fully integrate academia and public health practice, pursuing public health accreditation, which provides a framework for systematically assessing public health needs and services and ensuring continuous quality improvement, and then finally investing in public health infrastructure. Each of these opportunities has a legislative policy or funding component, and I'm sure you'll hear more about them as the interim progresses, but we are also happy to answer questions or have additional conversations, go into more detail on these offline. So next slide, Joseph, please. So by way of background, in Nevada, responsibilities for public health activities are split between state and local governments. The public health governance system is outlined in Chapter 439 of NRS. And essentially, the Division of Public and Behavioral Health is responsible for certain public health activities statewide, but also provides certain direct public health services in frontier counties. In addition, statute establishes a district health department in counties with a population of 700,000 or more, so currently Clark County, which is served by Southern Nevada Health District. NRS also authorizes the establishment of a health district in smaller counties, and these health districts may be formed by 2 or more adjacent counties, 2 or more cities or towns within any county, or a combination of county and cities or towns within it. And so Washoe County Health District is created using this model. In addition, statute requires all counties to have a board of health and authorizes cities to establish a board of health as well. And so Carson City Health and Human Services falls into this category. And so if this all seems confusing or complicated, that's because it is. Outside of Clark and Washoe counties, depending on where you live, certain public health services may be provided by the county, they may be provided by the city, and so others may be provided by the state through DPBH. The result of this whole system is that, especially in rural and frontier areas, it can be hard for residents to navigate services. It's hard to, or more complicated to ensure equity, and the system just doesn't function as smoothly as it could. And these challenges, I would say, were highlighted during the COVID-19 pandemic. Washoe, Clark, and Carson were able to stand up their responses pretty quickly because of existing infrastructure. And like Julia mentioned, those relationships with emergency managers. But it was a lot harder to do in rural areas where county boards of health may or may not have existed. And if they did, they may not have known that state epidemiology work was functioning in the background. Again, this is public health happens in the background. And so even those in positions of authority may not know that it's happening. So the opportunity here is for rural and frontier counties to pursue local administration of public health services. And this would provide rural governments more autonomy and independence over public health services and really streamline systems and processes. It's also an opportunity to review statutory language and consider providing additional opportunities or flexibility in creating health districts for formalizing these potentially regional partnerships or health districts in rural areas. We probably don't have the capacity or resources to stand up a health district in every rural county, but could foresee really regional health districts being created to serve areas that are located near each other. Next slide. So the next opportunity relates to establishing academic health departments. And an academic health department is a formal affiliation between a governmental public health agency and an academic institution. It provides mutual benefits around education, research, practice, and service. And really, it's a relationship where academia informs public health practice and the public health agency informs the academic program. It may involve a state or local public health agency, and the academic institution may be a school of public health, school of medicine or nursing, an entire university, or a community college. It usually takes the form of a letter of agreement, a memorandum of understanding, or a contract that identifies the goals, objectives, kind of mission of the partnership, as well as governs the activities and responsibilities of each partner and outlines the parameters for sharing resources. Academic health departments often include joint appointments in which faculty serve both as university faculty and public health agency staff, and agency staff teach or serve as adjunct faculty at the university. Often there is an opportunity for co-location of staff and faculty to increase collaboration and communication. And then many academic health departments involve robust internship programs at the public health agency, as well as joint research and other opportunities for collaboration. Next slide. So academic health departments build on and formalize existing informal collaboration between institutions of higher ed and public health agencies. And the idea is that it really is a win-win for both partners. So in terms of benefiting partners in the community, you're enhancing public health agency capacity, you're providing academia a way to give students practical experiences, as well as providing community connections for faculty to provide service in the community. You're increasing practice-based research. Often, health departments don't have the capacity to necessarily do the research or program evaluation that they'd like to with the data they have, but this allows academics to come in and use the data that's available to identify needs or issues or whatever. And then it brings real world experience to the classroom. In terms of improving the public health workforce pipeline, academic health departments help produce graduates who are better prepared to join the workforce because they've participated theoretically in a robust internship program, and so they have real world experience with a public health agency. In addition, it provides continuing education opportunities for the current workforce, for current public health agency staff, so they can move along the pipeline and progress as well. And also improves recruitment and retention of new public health practitioners because you're developing those relationships with students, with interns, and when they're done with school, they can be hired and they're ready to go to work at public health agencies. Next slide. So why are we working to establish academic health departments? This is really a way to institutionalize partnerships and allow collaboration to continue regardless of changes in leadership styles and priorities. It helps narrow the gap between public health academia and public health practice by bringing academics and practitioners together. There's this mutual beneficial and like reinforcement loop in having that communication. It's really focused on making the most of limited public health resources and ultimately improving the health of the community. Next slide. So the next way we'll talk about improving the health of Nevadans is by pursuing public health agency accreditation through the Public Health Accreditation Board, which is a national nonprofit organization that's dedicated to advancing continuous quality improvement among public health departments. The accreditation process involves a framework for systematically assessing community needs and services. So that's this one piece that Julia mentioned when we talked about the public health, the 10 essential public health services. And so evaluating what communities need and then ensuring that the services that we provide from public health agencies meet the needs. So really developing that plan and then ensuring continuous quality improvement. So it's not a one-time, we apply for accreditation and we're done, but it's really a framework to change culture and thinking and practices to create a cyclical process that ensures that as needs change, the services change and respond to those changes. At a high level, accreditation demonstrates public health agencies' capacity to deliver the 10 essential public health services. It challenges agencies to think about their roles and responsibilities, and it drives them to regularly reassess and improve the quality, efficiency, and effectiveness of the services they provide. And just to note that all of the state and local public health agencies in Nevada are currently pursuing accreditation or reaccreditation. So what does the accreditation process involve? It is a very complicated, not complicated, comprehensive review and assessment of public health agency operations and management. And it works through all of the areas listed on this slide. Next slide. So if it is a fairly complex or comprehensive process, why are we pursuing it? We are pursuing it because during the accreditation process, public health agencies are working toward being responsive to change and focusing on common goals of the department or the agency and the communities they serve. They're establishing a system of shared decision-making that involves agency leadership, staff, community partners, and customers. It's a very community-focused and engaged process where we're ensuring we're hearing, we're asking the community, what are your needs? We're taking their feedback and we're responding to ensure that we're meeting it. It helps support the growth and development of the public health workforce, aligns agency resources with the needs of the community, and provides relevant quality services and programs, and then also works towards developing strong partnerships that support better health outcomes for the communities served. So we've talked about improving public health in Nevada by pursuing local administration, academic health departments, and accreditation. And as Julia's mentioned, ongoing non-categorical funding is critical to each of these efforts, as well as other public health activities. And there are numerous opportunities to invest in the state's public health infrastructure. You've all likely heard that Nevada spends the least per person on public health of any state in the nation. Not only is the system underfunded, but the vast majority of available funding can only be spent on predetermined services like family planning or women's health, for example. We don't have funds that can be directed to the most urgent need of the day. So when we turn back to chlamydia or syphilis disease investigation, is the funding available? Will we be able to do it to the degree that we would like? It depends on having that funding, but we don't just have general funding that we can direct to whatever we need to do to respond to those community needs. And so based on what we've talked about, it's really important to look at funding opportunities as we look to support rural and frontier partners who want to set up regional health districts. We don't currently have funding to provide core public health services in an ongoing capacity in these areas. Right now, we're able to help support regional partners who are interested in setting up health districts through federal funding, but that is likely to go away. Funding would also facilitate the creation of academic health departments to fund an academic health department coordinator, joint appointments, or provide money to build out internship programs to improve the public health workforce pipeline. Current efforts to pursue accreditation for Division of Public and Behavioral Health are funded through federal funds as well, and those expire in June 2023. And ongoing funding will be necessary to continue the accreditation process. And really that focus on continuous quality improvement. Really pursuing accreditation is something that DPBH has been wanting to do for years, but just hasn't had the resources or the capacity to do it. So we have this opportunity through the funding from COVID to improve our public health systems, our public health infrastructure. But in order to maintain these improvements, we also need a commitment of ongoing funding that isn't specifically earmarked for specific tasks. DPBH has also developed mobile services to help improve public health responses in certain areas of the state. And these services currently rely on federal funding as well. And once this funding expires again, the services will not necessarily be able to continue without additional resources. And then finally, the COVID-19 pandemic has highlighted the need to expand epidemiology and laboratory services and oversight statewide, especially in certain counties. And so we'll need funding to support these services as well. I think probably most of you are aware that historically public health has received influxes of funding following crises or emergencies, but as soon as the emergency resolves or gets a bit better, funding tends to dry up and public health is left to do all of the things you heard about today, providing these core public health services that keep us all healthy, typically on a shoestring budget, especially in Nevada. But as we've seen during the pandemic, public health practitioners in Nevada are truly public servants. They're working tirelessly to keep Nevadans healthy, and they have done this for decades. We're just only now learning about it or seeing it because COVID-19 is such like in the forefront of all of our minds and news feeds. And they've done all of this work in the past with very limited resources. But again, as COVID-19 has shown, in order to ensure that we have the public health workforce and the resources necessary to keep the state healthy and to be better prepared to respond to the next pandemic, it's going to be important to consider investing in public health infrastructure. And I know that's going to be the topic of the SB 209 study, and so you'll delve much more deeply into it. At this point, I think we're happy to answer any questions about these opportunities or any of the information we presented today.
Thank you all so much for all of that information and some good insight into future action we can take. I have a couple questions that have come up. I'm going to go ahead and ask Assemblywoman Titus to kick us off.
Thank you. Thank you, Madam Chairwoman, for the opportunity to ask questions, and thank you for that presentation. It's always a difficult task to be in public health when at the same time you want to make sure that individuals have a right to that self-determination on their health. And it's sometimes that fine line that you have to intersect to do that. So thank you for all that you do. But again, we can't forget that right to self-determination. I've been wondering about the percent. Nevada notoriously has been low on vaccination rates. And the vice chair asked about what we're doing to get the COVID vaccine out there. But I'd like to ask you about the percent of overall vaccination rates that Nevada was before this crisis and where we are now. Because I'm very concerned that our vaccination rate was, I think, if I'm not correct, we're about 50th in the nation on all the other vaccines. And I'm wondering where we are with the COVID vaccine and making sure we haven't lost sight of the importance of tetanus shots, and other immunizations, shingles and pneumonia and flu and all of those. So can you give me an update on where we are on our overall vaccination rates? And then I have some other questions.
Julia Peak for the record, and then I'll turn it over to Carissa Loper as well. I just want to reiterate in public health, the risk reduction model and self-determination for folks to assess their risk and make decisions. Many public health programs outside of COVID, we look at that and we provide opportunities for intervention that may not be popular among everybody. Programs that we've stood up in the past include needle exchange programs that again appear to some to be encouraging drug use, but for us, it's an infection control measure that's pivotal for the people in the community that need it. Also comprehensive sex education programs, again, could be a very unpopular topic, but it's something to provide education and then again allow individuals to make assessments about their own risk. So risk reduction is a core part of a public health response and just allowing people to meet people where they're at, as I've said multiple times in this presentation. As far as the immunization rates, I'm happy to turn it over to Carissa to speak to those.
Thanks, Julia. Thank you, Dr. Titus, for the question. So we have notoriously struggled in Nevada with vaccination rates. However, we aren't the lowest. We are lowest for the flu, as we've seen. But for our childhood vaccination rates, if you're looking at the series of vaccinations that children are recommended to receive by the time they're 2 years old, we run middle of the pack. Probably about 36th on the last look that I looked at. So that's looking at that core series, Dr. Titus, DTaP, measles, mumps, rubella, chickenpox, hepatitis A and B for children. For adult rates with pneumococcal, shingles, and others, we also struggle to get those rates higher, but that's across the board, across the nation. So even if you were to look at the rankings, we may rank low, but the highest ranked state is looking at 60% coverage, right? So we do track all of that and we work with our local health authorities and all of our partners to continue to enroll more providers into our public programs like Vaccines for Children or the 317 adult program. We work with federally qualified health centers to make sure that they have the vaccines they need to serve their underserved and vulnerable constituents. And I think we do a lot of work, right, to make sure that the information gets out there and that we're working at the ground level to make vaccine more accessible.
Thank you for that, because I'd like to see us continue to try to push that needle so that those who want the vaccine, any vaccine, have access to it. And I think a lot of it, and you'll hear me bring this up time and time again, is access to care, information, trust the information they have. That public trust issue is huge. And so just making sure that anyone who wants the vaccine has access to it, and especially in the, not just rural areas, but especially in some urban areas where they don't have access to care, nor do they trust what they're hearing, or they don't hear anything. So I think it's important. Thank you for that. I didn't hear anybody under the public health discussion, I'm sorry if I missed it, address homelessness, because I think, as you probably know, I'm chair of the Lyon County Board of Health. And one of the things we always have on our agenda is homelessness, because for me, that is part of public health and making sure that people have a place to go when they leave the hospital. People have a place to stay, even if they haven't been in a hospital, that keeps them out of the hospital. And I'm wondering if that is under your umbrella of public health, because I didn't hear you mention homelessness.
Yeah, Julia Peak for the record. One of the things that public health does is we convene groups and or partner with groups who provide all sorts of social services in the community. And I'll just say, often in those groups, and especially looking at how we do chronic disease prevention, there's so many things we need to do prior to talking to you about your diabetes. And so you're not even ready to talk about diabetes unless you have safe, a safe neighborhood, secure housing, access to food, access to water, et cetera. And so we are part of those groups that look at that, though we don't have housing supports necessarily in public health. That's absolutely part of our discussion, because we're not going to reach higher levels of health, especially prevention, unless we assure that Nevadans, again, have access to safe food, safety, housing, et cetera. So definitely part of the conversation, just not highlighted in this presentation.
I would add that for homeless, we definitely look at homelessness as a, sorry, Dr. Titus, we look at homelessness as a targeted group, right? So if we're looking at immunizations or diabetes prevention work, we consider people who are homeless as a target group, and how do we best reach them with our resources and services?
Thank you for that. Sharon on, but one last, we kind of formed this little district ourselves amongst 4 counties, including Carson, Douglas, I believe Story, and Lyon. And when these folks call me, I actually refer them to the COVID hotline. And this weekend I decided to call the COVID hotline because I'm referring patients to the COVID hotlines or potential folks to the COVID hotline. And I got an answer machine that said, hey, we're closed. You have to call during business hours. We'll call back. It was 3-day weekend. We'll call back, on Tuesday. And I have concerns about that. If we are setting up, and we're calling it a hotline, why are we not monitoring it 24/7, consider a hotline? We would never on a suicide hotline say, hey, call back on Monday. Sorry, we're not here. And I'm wondering if we don't have, we have all these folks that we're doing exposure, contact tracing, those kind of things. And we don't have people to monitor the COVID hotline because folks are scared. Folks don't know what to do. They don't know where to turn. And I'm wondering about the COVID hotline, and should it just be called COVID information as opposed to a hotline? Or are we looking at stepping that up and actually giving people true information, having that one handoff where somebody answers the phone to say, hey, because we're doing these home tests. If we're sending out 500,000 home tests and people have now tested, they won't know what to do. And I'm worried that we're going to overrun even worse limited ability that we have now with staffing at our hospitals that are already incredibly busy, full for staffing issues and critical situations. Are we not going to be able to have some place for these folks who do this home testing and now not know what to do with the result?
So Julia Titus, Nikki Aker, Director of Carson City Health and Human Services, and you may be talking about our COVID hotline for the Quad Counties. Early on in the pandemic, we did have it monitored and staffed every day. And then as things slowed down, we went to a 5-day-a-week hotline. Really appreciate your feedback on that, and definitely we can look at that. And as people, we had a lot of people working the hotline at one point, and we've had individuals that have left. And because things were slowing down, we did not staff back up again. But really appreciate your feedback again, and we can certainly look at that.
This is Julia Peak for the record. I know Nikki speaks on behalf of the Quad County phone number, which is what Dr. Titus was referring to. I'll also say that we have stood up resource navigation services through Nevada 211, which has way more services than just COVID, but we did utilize that because it's a known number and resource. We also have the vaccine scheduling call center, and they are open 7 days a week because, again, people work at different schedules and have the availability to talk to somebody at off hours and on the weekends. Absolutely. As for the home kits, we don't disagree with you. We have a meeting actually scheduled for 1 p.m. with a call center to talk through what that might look like. Several states are standing up similar resources to help people navigate, regardless of the type of test they got. What's it mean, and what do I do now? And should I get therapeutics? Again, can't give clinical information, but can certainly take them through screening criteria and offer a resource. So that's absolutely something we're looking at and having conversations today.
Thank you for all of that. Nikki, thank you for that clarification. It was the Quad County hotline that I called, and I thought, hey, I've been referring people to this Quad County hotline. I ought to call that hotline and see what kind of information they're getting. So as you can imagine, I was a little bit dismayed when I got an answer machine. But I appreciate the clarification. Hopefully you may consider staffing that again with this current surge and these home tests. And I'm sure, Julia, in your meeting, you guys will be discussing some concerns about what to do with that information. Where do we have people turn? And how do we direct them so they don't flood our emergency room system even more than it already is? And again, thank you all. Thank you, Madam Chair, for the.
Please, Dr. Titus, if when you're instructing your patients, That hotline can be very busy. So if they do get even an answering machine during working hours, make sure they leave a message. I know that our team works very hard to return any messages.
Thank you so much for the information on that. Those hotlines can be very helpful, as we know, with telemedicine, right, for access. So I'm grateful for that information update. I have Senator Donyate on the my list for questions, but I kind of want to piggyback on what we were just talking about with information and access with a question that I had, if you don't mind. So I will ask about, really interested in this academic public health department idea and standing something like that up. I think one of the divisions I see across agencies is with getting this newest science and information into practice at the agency level. And so I guess my question for you is, right now, what is public health's role in addressing misinformation? And then how would the adoption of an academic or the standing up of an academic public health department help with that, that combating misinformation piece, in addition to all of the other things that they would do? But I'm more interested in that misinformation and how do we combat that and make sure people are getting the right stuff.
Yeah, Julie, I think for the record, I'll go ahead and start. And as you mentioned, we do have several of our local health departments on. And again, Dr. Titus is a county health officer and doing a yeoman's amount of work in Lyon County as well. So we can all speak to how we're working on this. We're doing so much public messaging and outreach. We have regular calls with the media to try to talk through that. We've also utilized our medical advisory team, an objective third-party group, to look at the science and make recommendations to us in the governor's office, so that we do have that group of extremely high-level doctors who serve in the community and public health experts. Some of the challenges with misinformation as well is that trusted friend or family member or community partner to deliver that information, as opposed to one of us delivering that information. And that's an opportunity for what you're going to be looking at in the interim study related to a public health service corps potentially, and perhaps we call it a community health worker program, but getting people who actually live in the community to share accurate and appropriate information to the community. That could be folks with no degree. It could be folks with a degree or working toward a degree within our academic health department model. I've been extremely impressed using a promotore model within our Hispanic communities, but again, ensuring that they have the correct and accurate information, that they are the messenger of that information into the community, and that if they do struggle with information, they know they can come back to us and we can do webinars, as Krista mentioned, to provide more information to the community, or really targeted messaging for the applicable communities. One of the things we did early on, I believe, with CARES relief funds was work with the Minority Health and Equity Coalition, who put together a great resource for us with focus groups of specific communities, so that as we looked at how we're going to roll out testing and vaccination information, they had already done the legwork. And I don't know if you're aware, but they function under UNLV, and they stood that up with having their faculty do the needs assessments and then the evaluation and providing that information to us. So they've been a pivotal part of that. The other thing I'll just say that the University of Nevada, Reno has done is they set up, through the Trudy Larson Institute, a training for staff as well, so that before they even hit the health departments for epi and disease investigation, that they have basic level knowledge of the information to provide, because that could be the single voice that an individual in our community talks to get accurate information. And we need to assure that whoever that person is, the touch point to the community member, they have the correct information, or they know who to call to get that information. So very long answer to talk about misinformation, but our local health departments are doing this as well. So certainly put it out to them to respond.
I realize it's a really complex piece of the puzzle to get our hands around, right? Misinformation comes from all kinds of sources, and it's difficult to identify and control those or combat them as best we can. I do see Ms. Aker and Mr. Dick on for the local health districts. I'm sure we have one from Clark County as well. I just don't see them popping up. So I'm gonna go ahead and start with Ms. Aker.
So yes, when, addressing misinformation, we look at what individuals are saying within our area, what we're hearing, what's being posted on our social media, and try and get that messaging out of the accurate information. We talk with a number of individuals personally as they're coming to our events. And it is a big piece of our response is making sure that we get that information accurately out there. We also use our Board of Health and our Board of Supervisors to, as we report on the response, to address any misinformation and make sure that our board has the information to talk with their constituents.
Thank you. Mr. Dick, do you have a response as well?
Yes, thank you. Kevin Dick, Washoe County Health District. And I think that there's misinformation and then there's disinformation. And we have people that are actively promoting information that is incorrect in our communities. And I consider that to be disinformation, not just people that are misinformed. And we can't really counter that on a point-by-point basis, because when you get to conspiracy theory type approaches to this, there are an infinite number of arguments and things that people can make up that we just can't take the time to rebut every single one. Our efforts are focused on providing scientific information and trying to help people in our community that are trying to understand and make up their minds about things so that they have that correct information. One of the things that we're doing is at our Board of Health meetings, we have many people that show up to make public comment, as we heard some of earlier in this meeting, where they're using public comment as a platform for misinforming our communities. And in fact, we had YouTube take down one of our Board of Health meetings because of all the misinformation that was part of the public comment at the beginning of the meeting. So we have now, after the public comment, we have added to our agenda an update on COVID-19 so that we can provide correct information to people that are viewing that meeting, and so that they get that and not just the misinformation that's being put out there. And I agree very much with what Julia Peak said about those conversations that occur between family members. Those are the types of interactions that are going to help with people that are vaccine hesitant to influence their decision making. And as Nikki Aker mentioned, we also have people available when we're doing our vaccination clinics to help to talk with people about the vaccine, the safety, and how that was developed. I would also like just to add briefly in response to Assemblywoman Titus's question about homelessness. I think that there's a definition that I'd like to share with the interim committee that I think will be helpful for understanding public health. And that is that public health is creating the conditions in which people can live healthy lives. And that's different than healthcare, where primarily that is providing medical treatment to individuals. I very much appreciate all the vaccinations that are administered by in our medical community. That is public health, but public health is really based on creating those conditions where people can live healthy lives. And all of the things that were presented formally in the presentation are aspects of that. But Ms. Peak gave a lot of examples as well in her response of other things that we do, working with partners in our community to try to establish those conditions for people to live healthy lives. And what we saw with the impacts of COVID-19 in our communities was we had large segments of our population that weren't living in conditions that were allowing them to live healthy lives. And the impact of COVID-19 just exacerbated those conditions that they were already in. And so it's really important that we we back up a little bit and we not just focus on so much the statutorily mandated responsibilities of public health around the prevention of disease, and really understand what the breadth of public health is that we need to be doing in the state. With that, I will wrap up, and I'd like to point out we have Michael Johnson on the meeting, who is representing the Southern Nevada Health District.
Thank you so much. Yes, I'm just going to ask Dr. Johnson if you would like to respond briefly to the misinformation and public health role.
Yes, thank you, Chair Peters. Dr. Michael Johnson, Director of Community Health, Southern Nevada Health District. I would echo what Kevin and Nikki said. We work very closely with our Board of Health and a variety of other boards that we work with the SNHD and provide, we have a section on each agenda for those meetings about COVID updates and reinforcing the scientific credible information around COVID. We also routinely address this on our website and our Director of Communications here. We've done a variety of media events that present the accurate information and dispel the myths around the misinformation. Also, within our clinical services, any touch point we have with patients or folks in our community that access our services, we reinforce the accurate messages and answer any questions that folks may have. Also, routinely through media interviews that myself and many others do here at the Health District, we routinely reinforce the the accurate messages and address misinformation. So we hit it from a variety of fronts since it is a real problem. I mean, at many of our testing locations, including this morning, we have anti-vaxxers show up who are saying vaccines don't work and a variety of other things routinely. So we do our best to address those with the folks that we serve. Thanks.
Thank you so much. I'm going to go ahead and ask Senator Doñate for his question now.
Thank you so much, Chair Peters. This question probably is more guided towards the DHHS staff. Can you talk about, I don't know if we've mentioned it today, but I would love to hear your feedback on, under the context of COVID-19, what has been the coordination challenges and opportunities between the state HHS team and tribes or indigenous communities? If you could touch on that, that would be greatly appreciated.
Julia Peak for the record. I just want to highlight that DEM and our PHP programs actually had a very good relationship with our tribal communities prior to COVID. So that was extremely helpful. But there are major coordination challenges to make sure that we are supporting each tribe in the way in which they want to be supported. And so that has included providing EPI support when they asked for it, also providing test kits. There have been challenges, though, with the relationship with our federal partners, the specific tribe and the state. We had an instance where federal partners came out to do a visit with one of the tribes, and neither the state nor the tribe thought they requested that support. And so we kind of scrambled to figure out how best to use the resource provided by the federal partner. And so there's great work to be done with our tribes. The other thing is turnover. Relationships are established, and then I've seen it through the COVID pandemic with the tribes, but really with public health professionals in general. When those relationships with those folks end, then trying to find a new contact within each tribe and making sure that the tribe knows which person within the health department to reach out to, that liaison work is there. Because again, they operate really independently. And when they need support, they need to know how they ask for that and in which way. We had regular calls with our tribal partners included throughout the pandemic, and that was a great opportunity just to provide information on resources and how to request. The tribes had opportunity to speak. We provided updates. Each local health department and emergency manager provided updates. So that just the communication, which is always how we fail or succeed, that regular communication was a way just to say what happened this week and what do you need and what's it look like. And so we had that, I would say, for at least a year as we were really standing up the response. It's dwindled, but really based on just the need and is it a good use of their time to meet with us. but great amount of work can still be done there. One of the things that we've established in DHHS, and I don't know if sister agencies have as well, is that we have tribal liaisons at each one of our agencies. We also have a tribal liaison at DHHS. So at the very least, the tribe knows to reach out to that person and that person can help navigate services. So we're doing our best, but there is a great deal of turnover, again, often within the tribe, that we just need to make sure that we're communicating with them regularly.
If any of the local health districts want to talk about their coordination efforts with the tribal communities that are located within their jurisdictions, we know that local relationship can look a little different than the state relationship. Nikki, Ms. Aker, do you want to respond about your agency?
Yeah, so we have had very minimal contact with the tribes in Carson and in Douglas. But absolutely, you know, if there were questions that we're able to answer them, the tribes have not reached out to us for any testing kits, any PPE. And we do have a healthcare coalition that we have encouraged the tribe to be a part of. But, you know, as Julia brought up, it's that the turnover that we see in the tribes on the local level within our local emergency management committee. There is a liaison. That person, again, it was turnover. They were very consistent in attending, and then we're getting a new one and is attending more regularly. But again, it's been difficult to have that relationship. We're not done trying because you know, we really value that partnership with the tribes. So so that's where we're at.
Thank you. Mr. Dick, do you want to respond as well?
Sure. Kevin Dick, Washoe County Health District. Thank you, Chair Peters. We do work with our tribes, both the Pyramid Lake Reservation and the Reno Sparks Indian Colony. However, you know, administratively, they're kind of siloed within the way our Indian Health Services operates and the just kind of the structure. But we do work with them. We do have, I joke, we have an international agreement with the Reno Sparks Indian Colony on our emergency preparedness activities, and they're conducting pods along with us when we have emergencies. We train as well with the the Pyramid Lake Reservation as a region. In fact, their tribal representatives were with us when we went back to national training at Emmitsburg on the response. And then we coordinate in various ways between our clinics and even our air quality monitoring operations with them. A lot of it is formal or informal as how we go about that. But we do try to work with them. I'm sure that our efforts could be improved in that regard.
Thank you. Dr. Johnson, do you want to respond for Southern Nevada Health District?
Sure. Yeah. I mean, we've had a similar experience. We routinely reach out and disseminate information to the tribes and contiguous surrounding counties. Although, as Kevin mentioned, the sort of siloed structure of tribal nations sometimes makes it difficult and challenging to work with. We'd like to do more with the tribes, but our experience thus far has been pretty minimal.
Thank you. Thank you for the responses, and thank you for the questions, Senator Vaniate. I do not see you on here, so I'm assuming there's no follow-up on that. We have one more item I'd like to get to before we move to a brief lunch break. I'm going to ask staff to go ahead with our next item, number 7, overview of the interim study on the COVID-19 health crisis pursuant to Senate Bill 209. Our senior policy analyst, Christy Robusto, will present this topic for us today.
Hi, thanks, Chair Peters. For the record, Christy Robusto, Research Division, the Legislative Council Bureau. As nonpartisan staff, as you're aware, I'm not here to advocate for issues. I'm here to assist members with policy issues brought forward to this committee. And just to reiterate, please always feel free to reach out to me or my colleagues at any time for any questions you may have. I will now review the COVID-19 interim study summary with you. This document, as well as the SB 209 bill page, can be found on the committee's webpage. So an overview of the interim study on the coronavirus disease health crisis pursuant to Senate Bill 209 from the 2021 session. Section 2 of the bill required the Legislative Committee on Healthcare to conduct a study during this interim regarding Nevada's response to the Joint Interim Standing Committee required Nevada's response to the COVID-19 health crisis. Since the responsibilities of the LCHC were transferred to this committee per Assembly Bill 443, the committee must conduct the study and make recommendations. There are 6 key areas that the study must address, and those are outlined for you. The first being examine the public health infrastructure in Nevada, which has been talked about throughout some of the presentations today. Such an examination may include an analysis of the strengths and weaknesses of the state's public health infrastructure, an analysis on how the state and local governments responded, delineated duties and jurisdiction, and coordinated during the COVID-19 health crisis, as well as how these items can be improved for future public health crises. Second, consider recommendations for increased funding for Nevada's public health infrastructure. Third, examine the long-term impacts of the COVID-19 health crisis on frontline workers and workers commonly considered to be essential workers. It should be noted that frontline workers mean any person who is at a greater risk of acquiring and transmitting infection due to unavoidable, close, and prolonged contact with others required to perform their job responsibilities. And that term includes, without any limitation, any workers that the committee determines are frontline workers. Fourth, to examine the health and economic impacts of the health crisis using an equitable perspective. Fifth, examine the benefits and challenges of implementing a task force composed of public and private representatives that seeks to support private businesses in Nevada's population areas. And finally, consider the creation of a public health service corps in Nevada, which you heard Ms. Peak mention earlier today. The committee needs to report the results of the study and any recommendations concerning the response and future public health crises to both the governor and the LCB for transmittal to the 2023 legislative session. And it's also important to note that the bill did not contain any additional BDRs related to the study. Therefore, should the committee choose to recommend any study related to BDRs, they would have to come from the 10 general BDRs allocated to the committee. And with that, Chair Peters, that concludes my presentation. We're happy to take any questions.
Thank you for that. As Ms. Robusto stated and as earlier discussed in the committee brief by Mr. Ashton, as part of this committee duties, we are required to complete an interim study on the COVID-19 health crisis pursuant to Senate Bill 209, as just described by Ms. Robusto. Are there any questions from the committee? I see I've lost a few folks. It's probably about that time. I don't see any questions about this particular piece. Wanted to let members know that I decided on assigning this interim study to Vice Chair Doñate, who is also the sponsor of this bill during the 2021 session. He will take charge of it and complete the study requirements with the assistance of staff throughout the next months. Every other committee meeting, Senator Doñate will report back to the committee on the progress of the study. You will have the opportunity to provide feedback and ask questions We are planning on hearing the study results and recommendations this summer during one of our meetings. Additionally, if you have any comments, ideas, questions, or concerns regarding the study, please feel free to reach out to Senator Joniate at any time. Are there any questions about that particular process? Assemblywoman.
Thank you, Madam Chairwoman, and thank you for Vice Chair to be willing to serve that place. Thank you for your bill. Ultimate information and present back to the committee is done in a timely manner so that indeed, because is the one that has the 10 potential BDRs, that we get it in so that if indeed study, we'll have it in time to do so.
That is our hope. Actually, my hope for the entire committee is that we hear recommendations throughout the period of our meetings for potential BDRs. So we can individually be considering those for personal BDRs as well as consider them as a committee and continue to have those discussions and vet those bills as or bill ideas as they come up. So I appreciate that comments, Assemblywoman Titus. Are there any other questions before we briefly break for a quick lunch? I apologize. I know a 15-minute lunch is not a lot of time to get some sustenance, but I did try and warn folks to be prepared. So at this point, I'm going to take a quick lunch break, about 15 minutes. It is 12:40 right now. So let's look at getting back here at 12:55. If we can, we still have quite a bit to get through. So I would like us to get started as soon as we possibly can. Thank you all, and we'll see you shortly.
Here, the broadcast is live and you may call the meeting back to order when you're ready.
Welcome back, officially back to order. Thank you so much for accommodating that brief break. I hope everybody got some kind of sustenance and a potty break before we jump into this next section. I'm really excited about this particular piece. As most folks know on the line, Medicaid is one of our largest budget items. It impacts some of the largest groups of our population base. And we just went through some pretty significant and reasonable changes to Medicaid and COs in particular. And I know that our state Medicaid program is continuing to work through the pandemic and other areas that require our attention. So I'm going to go ahead and open up our agenda item 8, which is the overview of a Medicaid program in Nevada. We have Administrator Suzanne Bierman here with her deputy administrator and with her deputy administrators. We're graced with most of them, I think, if not all. I'm going to go ahead and let you start, and then following your presentation, we will take a few questions from our committee.
Great. Thank you for the opportunity, Chair Peters. Happy to be here today to talk a little about Medicaid with you all. Do you want to mention, you're correct, we do have all of the Medicaid deputy administrators here to help with questions and answers as needed. But I also wanted to welcome Robert Thompson. He's the Deputy Administrator for the Division of Welfare and Supportive Services, and they manage Medicaid eligibility. So we handle the program and the service side, and they do eligibility. So I appreciate him joining us today as well. So I will start and then hand it over in a couple places to Deputy Administrator Thompson, and then happy to answer any questions. Next slide, please.
They're not seeing a screen share.
Okay, let me see if I can get that pulled up. I apologize.
And I apologize for not recognizing that we had Deputy Administrator Thompson on the line as well. I'm sorry about that. Thank you so much for being here also.
Good afternoon.
Bierman, do we know who was supposed to be sharing screens? Maybe we could get broadcast to help us.
We did just get an update. It's going to be Deputy Administrator Phil Burrell, and I just got a note that he's pulling up the slides right now. So I think we should be good, but if not, and broadcast could help, that would be great.
There we go. Welcome.
And Chair, this is Bryce with Broadcast. We're still not seeing a screen share on our end.
I think that Mr. Burrell was just logging in, and there we go. I see.
There we are.
Thank you. Go ahead, Administrator.
Great. Thank you so much. And apologies for that slight delay and technical difficulty. So here we have the overview of our presentation. As I mentioned before, thrilled to have Deputy Administrator Robert Thompson joining us. And if you could advance to the next slide, please. We have kind of an overview of a slide we use pretty often when we do these presentations, kind of some of our fast facts, we call them, about Medicaid in Nevada. So just some really high-level statistics about the program. First and foremost, Nevada Medicaid is a health insurance provider to low-income residents of the state. As you can see here, currently about 1 in 4, 25% of the state's population does receive their health insurance coverage through Medicaid.
We'll talk more about this. We have several slides dedicated to this, but have seen a significant growth in the program over the course of COVID and the public health emergency. So as you can see here, we've had over 200,000 additional individuals added to the program during the time of the public health emergency. That's about a 33% growth in the program. We can talk about some of the reasons why, and as I mentioned, we have a couple of additional slides that dig into that in a little bit more detail. There's high-level information on the expenditures. As you mentioned, certainly one of the state's large budget items. I want to reflect that here. Additionally, we play a big part in maternal and child health and are always looking for opportunities to work with our partners at public and behavioral health. And do just want to flag that we pay for 60% of the births in Nevada and are really interested in working to improve maternal and child health outcomes. We didn't include a lot of information on that today, as we've heard that there will be additional interim health meetings that really do a deeper dive on that, but did want to flag, in our high level statistics that we do play a large role in providing those services in Nevada. A little bit on our service delivery models, and we'll have additional slides on this, and want to flag that the next presentation is actually a more in-depth presentation on managed care, but here want to flag that about 76% of our enrollees do receive care from the now 4 managed care organizations. And I know that there's also an opportunity this afternoon to hear from them directly. Just some high-level demographic information about the program. About 42% of the program enrollees are children. About 10% are dually eligible. Do you want to flag that that particular dual eligible population and the elderly and disabled, while they do make up a smaller percentage of our overall enrollees, they do account for a large percent of our programmatic expenditures. So that, and then flagging that Medicaid pays for some benefits that commercial health insurance doesn't, like long-term care. You can see here that Medicaid paid for about 62% of nursing facility bed days. Next slide, please. Okay, there's 2 slides. As I foreshadowed, we'll be spending a little bit more time talking about our caseload increase. And here you can see over the last year. So not a lot of pre-COVID numbers on this particular slide, but you can see the steady incline even over the last year, up from 765,000 enrollees, up about 100,000 from that to close to 860,000 as of November. On the next slide, you can see the historical trends with the November 2019 data included. And I will say pre-COVID and that whole, pre-February 2020 number back years before that was pretty consistent, our enrollment at around 645,000. So this just kind of gives you a little bit of a more zoomed out insight into how our enrollment has changed over time. So from that pretty consistent around 645 to the steady increases that we've seen during the time of the public health emergency. So something that we've talked about a lot is how the public health emergency has impacted the Medicaid program. Definitely provided opportunities to ensure that Nevadans have and remain insured during the public health emergency. There are something that we'll talk about later in the presentation as well. One of the hallmarks of the Medicaid program is that it's a federal state partnership. So the Families First Coronavirus Response Act, which was passed by Congress in 2020, did a couple of things to help states address the public health emergency. And one of those was providing some additional federal funding, but there were also coverage continuity or maintenance of effort requirements attached to that additional federal financing, which is really restricted the way that people leave the program during the time period of the public health emergency, and we can talk about that in greater detail. And again, one of those issues that I'm very glad that we have our counterparts from Division of Welfare and Supportive Services who do eligibility determinations joining us today to discuss in further detail. Next slide, please. So this is just a high-level overview of some racial and ethnic demographics that kind of show you that Medicaid serves diverse populations. And I always just like to focus on the fact that Medicaid, to me, is a health equity program, and the decisions that we make in the program do have implications for the diverse populations that we serve. So I'll now turn this over to my colleague from the Division of Welfare and Supportive Services, Deputy Administrator Robert Thompson, for an overview of Medicaid eligibility. Thank you.
Thank you, Suzanne. For the record, Robert Thompson, Deputy Administrator for the Division of Welfare and Supportive Services. So the Division of Welfare and Supportive Services is the entry point for SNAP, TANF, energy assistance, child care, child support, and Medicaid. The Welfare Division is an integrated agency, and by being integrated, we do allow our customers to apply for SNAP, TANF, and Medicaid on the same application being processed by the same caseworker. Not all states offer that. Some states still require their customers to apply for SNAP at one agency and Medicaid at another agency. Next slide, please. So the Division of Welfare and Supportive Services has more than one way to apply. We still offer in-person service. We have our offices throughout Nevada and in our many rural cities. So we can offer face-to-face, but through the pandemic, we have really worked hard to shift our customers away from face-to-face service and coming into our lobbies and to apply via Access Nevada. Access Nevada is our tool to apply through our website. We also allow our customers to apply over the phone. They can apply for Medicaid over the phone without completing an application. Nevada does allow for verbal attestation of signatures for Medicaid. That is not allowable for SNAP or TANF at this time, but right now we can let our customers apply for Medicaid verbally. We have over 100 on-site community partners through non-traditional doors. We are in community centers, detention centers. We have our workers going to the homeless shelters, approximately 100 throughout the state, where we actually go out into the community and connect with those customers that cannot reach us. We also accept referrals through the health exchange, and our hospitals can sign up for presumptive eligibility, which means we allow the hospitals to determine eligibility. That's for 2 months, a person coming into a hospital. If the hospitals are certified, they can do their own eligibility, apply, and then we must reprocess the application within 60 days. And next slide, please. And I will turn it back over to Suzanne.
Thank you so much. So on this slide, I'll talk a little bit about enrollment into the Medicaid program once eligibility has been determined by the Division of Welfare and Supportive Services. From that point, an applicant can choose their managed care organization preference in their application. Again, I know we're going to talk much more about managed care, but I just want to highlight here that managed care is the service delivery model that we use in the urban counties. So Clark and Washoe, and for all of our populations, a handful of exceptions, the most significant being that the age, blind, and disabled population is not served by managed care. So just wanted to provide those caveats here as we talk about enrollment into managed care plans, and note that for about 25% of our population, this really doesn't apply because they're in the state's fee-for-service program. So the managed care plan coverage becomes effective when the eligibility file is received and when it's entered into our IT system, which is called the Medicaid Management Information System, or the MMIS. Then from the plan side, the member gets a welcome packet. So just kind of wanted to provide a really high-level overview of how this works for a member from a member's perspective. As I mentioned previously, for our enrollees who aren't in managed care, they receive services from fee-for-service. As I mentioned, that's primarily in the rural areas, and we work with a vendor to pay providers directly for the care that is provided under the state's fee-for-service benefit. Next slide, please. Great. So here I have a little bit of information on services and benefits, and Medicaid does provide really comprehensive coverage. As I mentioned before, there are some benefits that Medicaid covers that aren't typically covered by commercial insurance, such as long-term care stays and non-emergency medical transportation. But did just want to note that there is a difference in federal law that kind of divides services into mandatory, which are required, and then optional services, which are at the election of the state. So this kind of goes back to the whole federal state partnership that's the hallmark of the Medicaid program, where the state can make certain programmatic decisions as long as the overarching federal framework and rules are being followed. So here I know a lot of the optional services that are listed here don't really feel optional if you're in need of those. And I know during special session, a lot of us had some really difficult conversations around optional services and how they really are very needed and make a huge impact on the health and lives of the Nevadans we serve. So just wanted to flag that there is that distinction in the federal framework. And this is also not an exhaustive list of either all of the mandatory or optional services, but just did want to provide some high-level information on the services or benefits that the Medicaid program provides. Next slide, please. Okay, I think we talked about this one, so I won't spend a lot of time here, but just a graphic depiction again that shows the two service delivery models that we use here in Nevada, with the vast majority of the population being served by the managed care organizations, which again, you'll hear much more about in the next presentation. And then the fee-for-service program, which again serves the age blind and disabled and members in the rural and frontier communities. Next slide, please. Okay, so a little bit more information on fee-for-service, since we're not having a standalone presentation on this one, but just want to note a couple of details about the program. Individuals may receive all medically necessary services from any provider enrolled in Medicaid. Primary care physician referrals are not required for specialist care under the fee-for-service program. One of the other differences between the two is that managed care organizations really provide a level of care coordination that isn't available in fee-for-service. And again, as I mentioned, the state directly pays those claims to fee-for-service providers. Next slide, please. Okay, this is just more information on the state federal partnership that is, a really significant part of how the Medicaid program works, is that it's jointly funded and overseen by the federal and state governments. So here you can just kind of see that feds and state together pay for the funding that goes to providers. Of course, in managed care organizations, it comes through us to managed care organizations to the providers, but just wanted to flag here that the federal government pays a guaranteed percentage of all of the costs, and the federal share is something that we refer to as FMAP, and that acronym is the Federal Medical Assistance Percentage. So we include an acronym slide, but that is one that we use pretty often, and again, just refers to the amount of the programmatic expenses that are covered by the federal government. Next slide, please. Okay, so this has a lot more granular information. When we're at the budget committees, we usually spend a lot of time talking about this. I won't go into it in great detail here, but do just want to outline a couple of things about the financing of the Medicaid program. Again, the federal medical assistance percentage, the FMAP, is the share of the cost of the programs paid for by the federal government. As you can see, This varies by eligibility category. And as I mentioned before, there are certain enhancements that the state is currently receiving. You can see on this chart, there's one that says with FFCRA, so that's the Families First Coronavirus Response Act, which I mentioned, which has provided an enhancement of 6.2% additional funding for the time of the public health emergency. And again, there's always a nuance in Medicaid, so that applies to the eligibility groups with the exception of the newly eligible adults or the Medicaid expansion population, which already was receiving a higher federal share of funding as compared to the pre-expansion eligibility category. So you can see that 90% here is the federal matching for that newly eligible adult or Medicaid expansion population, and then a lot more granular information on the FMAP enhancements and how those vary by eligibility category. Next slide, please. So this is just a high-level overview of kind of some of the core requirements for Medicaid reimbursement. You know, sometimes we get questions about why is Medicaid not reimbursing for these services. So I think just a good high-level framework to keep in mind. Of course, Medicaid only pays for people enrolled and eligible for the program, only for services that, going back to that slide of the required and optional services, are services that are covered in Nevada, and those are all outlined in our contract with the federal government, which is called the state plan. So a lot of times you hear us talk about state plan amendments or SPAs, and those are really just amendments to the state's contract with CMS, that's our federal partner, the Centers for Medicare and Medicaid Services, that allows for changes to the state's Medicaid program. Next, the provider has to be enrolled in Medicaid. And lastly, the services that are reimbursed have to be medically necessary. So just kind of 4 pillars that are sometimes helpful to think through. So just wanted to highlight that. Next slide, please. Okay, here, it's been a busy years. So I wanted to highlight some of the work around COVID and additional things that we've been working on since this committee or the Interim Health Committee previously has met. So as I mentioned previously, have really been working to ensure that we are evolving along with changing federal rules. You saw all of our caseload slides that represent that 33% increase in our program. Also implemented some program flexibilities that were needed during the time of COVID to make sure that we could provide needed services and quickly respond. Also, again, evolving with additional federal options and working in that overarching federal framework as additional options for COVID testing, treatment, vaccination became available for even previously uninsured groups. The state Medicaid agency here, DHCFP, worked to implement all of those. So just wanted to flag that. Also working closely with the Division of Welfare and Supportive Services to implement legislation from the last session, and in particular, some eligibility and coverage expansion options. I know we're going to talk more about all things maternal and child health related at a later meeting, so won't go into great detail about this, but working with our partners at Welfare and Supportive Services to implement presumptive eligibility. Deputy Administrator Thompson briefly touched on hospital presumptive eligibility, but we're working to expand the settings in which presumptive eligibility can be determined for pregnant women. That again was coming out of last session, and some expansions related to coverage for lawfully residing pregnant women who haven't been here for 5 years. So just wanted to highlight those expanded coverage opportunities. Also, we have worked to implement additional provider types and services to support maternal and child health, doulas, community health workers. We have pending amendments to the state plan to allow us to reimburse those providers for services, and have created provider types that will enable that reimbursement for those critical services, and are working on provider education related to those new opportunities. We've also been working for several years to develop additional services for children in foster care, specialized foster care in particular, something our team has been working on for the past couple of years. And also are working to improve access to substance use disorder and other behavioral health services, but wanted to flag a lot of the work that is being done right now around improving provider capacity to serve individuals with substance use disorders. Next slide, please. Okay, on the next slide, I'll pause for a second to give the presentation time to catch up, but we outlined some challenges and opportunities, and these closely align with things that we have highlighted as strategic priorities for a number of years and are continuing to work on. So one of those is promoting continuity of coverage and care coordination. I think you heard us talk pre-COVID pandemic a lot about the remaining uninsured in Nevada, and certainly the public health emergency has changed all of that, and data's in flux, and we can talk more about the process of what is called in technical Medicaid parlance, the unwinding of the public health emergency, which is basically the process of going back to doing those renewals and redeterminations on the normal process that existed before the public health emergency. So really working hard with Division of Welfare and Supportive Services to prioritize continuity of care as we work through that process. Always interested in things that we can do to enhance and strengthen primary care opportunities. Would flag that we've been working closely with public and behavioral health to hopefully transition the Office of Primary Care over to the Division of Healthcare Financing and Policy to work on some of those programs that allow opportunities to enhance the workforce. A lot of programs with HRSA, J1 visas, and other opportunities to grow our workforce. Addressing children's behavioral health needs. I know there's mention of this in the public and behavioral health presentations this morning, but just really aware of those increased needs for behavioral health generally and children's behavioral health specifically. Always working on initiatives and opportunities to advance affordability and value-based purchasing initiatives. And we have another presentation related to that this afternoon. So just want to be cognizant of the fact that we know that Medicaid is a large part of the state's budget and want to be good stewards of taxpayer dollars and smart purchasers of care. So always looking for opportunities before a crisis, maybe to be a little bit more proactive in how we can increase the value of services we provide. As I mentioned a little bit before, are aware of the workforce challenges that face the state and working with partners to help address those. Also, the continuous coverage requirement is the technical requirement that has led to kind of the pausing of redeterminations during the public health emergency. So as I mentioned before, planning for the unwinding of those requirements when the public health emergency ends, and promoting coverage and try to reduce churn throughout that process. Another thing, I know we've talked a lot about COVID, and I appreciate the state biostatistician presenting before me this morning on the vaccination rates for Nevadans, and to just want to flag that in Nevada and every state, the Medicaid population significantly lags the overall state average for vaccination, COVID vaccination uptake. And that's something that we've been working really closely with our managed care organizations to try to address, but is certainly a challenge for us. So I know that was a lot, but just wanted to give you all a high level overview of the program, some of the things that we've been working on and some of our ongoing challenges and opportunities. And also wanted to provide the opportunity for Deputy Administrator Thompson to add anything here related to challenges and opportunities from the DWIS perspective. Sorry, Division of Welfare and Supportive Services. Thank you.
Thank you. And thank you, Deputy Administrator Thompson, as well, for your time today. Are there any questions from my committee members? I have a few Sorry, I'm having to expand my screen a little bit to see. I know Assemblywoman Titus has questions, and then I have Assemblyman Hafen as well. Assemblywoman Titus, I believe, is having
Right.
her video off, so I think we still have her audio.
Great.
Her audio, so go ahead.
Yes, you do. I apologize, Madam Chairwoman. I'm going to leave my video off. Hopefully my audio will stay a little bit better and a little stronger without the video on, but I definitely am sitting here in person. I have a ton of questions, but I'll try to keep it to policy because I ask a lot of these questions at IFC on the Monies Committee, but at the IFC committee, I asked a policy question and you were going to get back to me regarding the Medicaid spending trends by provider type. And I still don't have that. And I really think that you mentioned we've had a 33% increase in Medicaid enrollment, but you didn't say anything about what percent increase we did on providers. You mentioned different provider types, but not how they're being utilized. And along with that same question, of that 860,000 Medicaid enrollees, that doesn't necessarily mean they had access to care. And I asked this question a lot. I've never gotten an answer. I would love an answer. Now, you keep saying, well, it takes time. There's a delay in the provider's billing. I still need to know, are those folks accessing care and what the provider spending trends are?
Thank you for the questions, Assemblywoman. So I do believe that we submitted that full utilization report that we conduct to LCB. So happy to follow up, or I'm not sure if Mr. Kucera is still on and can speak to that, but happy to make sure that we get that to you. Happy to walk through it. It's quite a long report, but we do have and did provide that information to legislative staff.
Great, thank you for that. Hopefully I'm still good. If I turn my video on, you still get that, but I'd love to see that. Looking forward to that. Did you also include the percentage of increase in providers that have agreed to see Medicaid patients? Because one of the things I've pointed out time and time again, I would see whoever walked through my door, but the reality is I couldn't get them referred to anybody. Have we improved that?
Right. So I will say that we do have challenges in knowing who is taking Medicaid enrollees in real time. It's something that we continue to work on. It's just a really challenging question to answer, but I completely acknowledge that it's a really important question. We do have reports that we do on a regular basis around access to care. There's actually a federal regulation that applies to the fee-for-service program called the Access to Monitoring Review Plan. And we just updated that when we went through the AB3 process, which was the budget reductions, the 6% rate reductions that we worked to implement, and then due to some additional funding that was identified during session, didn't end up implementing that, which I think we're all really grateful and grateful that that didn't come to fruition. But we did a lot of work with our federal partners to actually get approval and effectuate those rate reductions. We were still in the process of it during legislative session, but we have updated those access to monitoring review plans. And on the fee-for-service side, that's really the best report that we have about the overall access to care. And again, it is updated on a regular basis. So we can also provide that information. I mean, unfortunately, I don't have a data system that says X, Y, and Z providers across the state are, accepting new Medicaid enrollees on a daily basis. That would be wonderful. I don't know how to get there, but open to all ideas on that and happy to provide that access to monitoring review plan. I would also note on the managed care side, which serves about 75% of the state's population, there are different federal requirements around network adequacy. So that's something that we're constantly monitoring and working with the plans on to ensure that they are meeting those. It's kind of the managed care version of the access standards. So they may also have additional information to provide during their presentation on that today, but did want to flag those two ways. We can provide additional information on provider enrollment and the number of new providers that we have seen over time. I don't remember off the top of my head if that was included in the information that we most recently provided to LCB, but I can go back and confirm.
Great, thank you. And also, one of the things we're looking at in behavioral health is the concept of computer programs of open bed, so that we know if there's a bed available, especially on the mental health aspect of it. And is there any thought of Medicaid looking at using such a program so that as a provider, we can know maybe what Medicaid providers are out there would receive a patient, and maybe that could be thought that moving forward we could solve some of this referral problems. Having said that, I also want to ask about that 6.2% increase in FMAP that we continue to see. You gave that list in that chart, which I appreciate. But those funds that then they're offsetting the funds that we would be spending. Is that not correct?
So they're really helping to absorb some of the increased costs that we have in having 200,000 plus people on caseload is really where we've dedicated and prioritized that additional funding into our budget.
So then is there any of that residual then sitting in the budget that's not used because now we've taken that money from the federal government? Do we have an excess there that has not been allocated to say to your increased rates or reimbursing providers or some incentive to see Medicaid patients?
Yeah, so I will see if our fiscal deputy wants to chime in on this question, but I do believe, there's still a lot of uncertainty around how long the public health emergency is going to last. There's going to be a period of time when we are working to reinstitute renewals and redeterminations, but perhaps Deputy Administrator Thompson could provide more information on this, but that's not an overnight process. So it's not like a flip the switch and the 230,000 individuals have been redetermined at once. So that will be a gradual process, and there's still uncertainty at the federal level around the enhanced FMAP. Currently, under current law, which is the Families First Coronavirus Response Act, that FMAP will end at the last day of the quarter in which the public health emergency ends, and we'll still be working on renewals and redeterminations during that time period. So there will be a time period where we still have enhanced caseload and are no longer receiving the enhanced FMAP. So we're trying to budget with a lot of uncertainties right now. So that would be my high level answer. And I would pause to see if our finance team has anything they would like to add, but hopefully that's helpful.
It doesn't, and the finance team, because this is getting lengthy, they can respond. And I'd like to see all the information that you say you've provided. It'd be great to send it out again because we do have new members on this committee and perhaps didn't see that. So I haven't seen it. I'd love it. Final question. One of the many times we've spoken, there's been questions regarding removing folks from the roles. And as folks have gotten employed and there's other options for them out there, and as we know, without being employed, when this initial happened, we had a lot of people leave our state to move in with other family members, et cetera. And it's been a concern about removing folks from the roles. Where are we in that process?
I'll start and then invite Deputy Administrator Thompson to add or clean up any of this I don't get right. But there are instances in which the Division of Welfare and Supportive Services can close eligibility, even right now, during the continuous coverage requirements that we've been talking about. And those are things like if someone dies or moves out of state or asks for their case to be closed. Again, those are the ones off the top of my head, but I would invite him if there are other reasons for which they are currently able to close cases. I know that there are a handful of exceptions, but not for over income unless there's been a request to have the case closed.
So Robert Thompson, for the record, Suzanne, you are correct. The only other exceptions we make are cases that were approved in error or a customer refusing to comply with our investigation and recovery if we suspect fraud and they will not cooperate with us. But other than those, you are accurate. We are not closing any of those at this time.
All right. Okay. Thank you. Thank you, Madam Chairwoman, for the questions, and sorry about my video.
Thank you. No problem. We understand technical difficulties in this day and time. I just dropped off twice during the presentation because of my own technical difficulties. So thank you for your questions. I have Assemblyman Hazen next, and then Senator Hardy on the list after that. We do have another couple things to get through today, so let's keep these as specific as possible to what the presentation was on today. And if we have additional questions that we can move into other, either offline or other topic areas, we can do that in future topic items. So go ahead, Assemblyman Hagan.
Thank you, Madam Chair. And I just want to thank everyone on this. I look at the Medicaid information that you just presented, and it looks like you guys have done an absolute excellent job at getting people enrolled. Adding 200,000 people to the rolls with 33%, that's just absolutely amazing. I know during regular session, we were trying to figure out how to get people enrolled, and it looks like you guys have done it. And so congratulations on the great work. And I'd just like to, I know that one of the challenges for you was the primary care. Chair Peters and I actually spoke yesterday about the workforce issues. We feel you there, and we're hoping that something during this interim we can try to address that and bring something forward to help that process, because it's not just in Medicaid, it's across the whole spectrum of healthcare right now. And so I feel your pain there, and hopefully we can do something to help. The question that I have was, with this increased growth in the Medicaid coverage, do we still have an idea of how many people or a percentage of the population that's still uninsured that qualifies for Medicaid?
I think, thank you for the question, Assemblyman. I think it is a great question. It's something that I wonder about a lot. My sense of it is that we're going to have to wait until after the public health emergency and see what it looks like once we're done with redeterminations to really have a sense of what the new normal is, to compare to both during the time of the public health emergency and pre-public health emergency, to really compare those remaining uninsured numbers pre-COVID right now, and then what we're looking like once we're done with the unwinding of the public health emergency. So that's the best answer I know to give, but I really think it's a great and fascinating question, and wonder a lot about how much of that growth has come from the remaining uninsured. And we've talked a lot about that report from 2019 from the Gwen Center, which was the last real comprehensive report or data point that I have that looked at this question in great detail, but really to look at it and see what that looks like when we're done with unwinding. And the federal government, our partners there, Centers for Medicare and Medicaid Services, are really interested in this question as well, and trying to promote continuous coverage to the extent possible. I mean, certainly I think everyone knows and realizes that there will be people that are no longer eligible because of income, and those are appropriate disenrollments. I think there's widespread agreement on that point, but really asking for a lot of data to track this issue. So from states and our colleagues at Division of Welfare and Supportive Services, I know that they're going to be requesting regular reporting on this. So I think it's a great question, and I don't know how we ever say, this 200,000 was that 200,000, but I think, just thinking through it, there's got to be overlap there, but I don't unfortunately have any report to point to, and I think it would be pretty difficult, if not impossible, to do while we're still in such a volatile state with, so much flux in all of our numbers that will occur once we start redeterminations.
Completely understand. When those numbers do become available, I'd love to see them. Because again, I think you guys have done an absolutely amazing job at trying to capture as many folks as possible. And so I just didn't, the other question, you probably won't have an answer for me today, but the remaining population percentage that you guys are targeting to try to get enrolled.
Right.
And again, you can get back to me later with that, because I know the chair would like us to hurry up. So.
Okay, well, thank you for your interest, and we would be happy to come back and provide regular updates on these questions, because they are really important to us, and that goal of promoting coverage. So happy to provide ongoing updates on those questions.
Thank you, and thank you, Chair.
Thank you. I think we will continue to be interested in the unwinding process and what comes of that as well. So I'm sure we'll see you multiple times in the interim. on this particular topic. Senator Hardy, your questions, please.
Thank you, Madam Chair. I appreciate the presentation. Simple, direct, and actually optimistic for helping people through their difficult times. And quite frankly, even though we have heard over and over how Medicaid doesn't pay all the costs that hospitals have, were it not for Medicaid and being able to cover so many lives, hospitals would probably be in a worse position, which means the loss of the economic benefit now. I don't know if we've been able to figure out the loss of the private benefit, the economic benefit in this COVID era or emergency pandemic. We know that we've probably had a loss of income for the private sector. Has there been thought of how this portends to the actuarial approach to what happens with what we're discussing with a single source or a look at, has there been a juxtaposition actuarial study to say what's going to happen if we go to a single source like we virtually have a partial single source to look at modeling right now with Medicaid? Is that a convoluted question and that I'm not expressing well enough to make sense?
Thank you for the question, Senator Hardy. I think it's a really interesting question, and I'll take a shot at it, and hopefully my responses do a good job of at least addressing part of your questions. So one thing, the Medicaid managed care rates do have actuarial requirements, and they have to be actuarially sound. So we do work with a contracted team of actuaries that's really specific and highly technical skills. So we have to certify that our rates are actuarially sound for Medicaid managed care to the federal government. So we do work on that piece. I think your broader question might have had to do with coordination between Medicaid and the other payers and the public option. Does that sound right? That we'll be talking about later today in the presentation on Senate Bill 420. That's what I was imagining you were alluding to.
That's what I was trying to say.
Okay, great. So there is an actuarial study, and this is a part of the presentation that I'll present on SB 420 that it requires, SB 420 requires the Department of Health and Human Services to apply for and submit what's called a 1332 waiver, and I'll explain that in my next presentation, to the federal government. And as one of the requirements of a 1332 waiver, there are requirements for actuarial analyses and studies that accompany any 1332 waiver. So, and there are provisions in SB 420 that promote alignment and coordination between Medicaid managed care and the public option to be developed. We're working on that. That's a lot of my presentation on SB 422. It's a process, and that plan is set to become effective or operational on January 1st of 2026. So still very early in the implementation phases of all of that work, but there certainly is thought to how Medicaid can best align with those new public option opportunities that are being developed, and both Medicaid managed care rates and 1332 waivers do require some actuarial analyses. Is that hopefully helpful?
I guess that's part of it. How much did we lose in the private industry with COVID, as it were, and depending on Medicaid? What was the overall hit to private industry, private hospitals, private care providers, dependent now on Medicaid, but not being able to get as well remunerated as they were with private industry insurance type plans?
I think that that's the question. Yeah, and Administrator Bierman, if you have an answer, that is great. If not, Senator Hardy, that is a piece of this interim puzzle that I would love to continue to explore with our private stakeholders to talk about what some of these losses have looked like and what the future of private industry looks like as we unwind the from the public emergency and as more people move off of hopefully Medicaid and onto those private insurance, or as we establish the state option, the public option, and people have that option as well. So Suzanne, if you have I'm sorry, Ms. Muir, if you have something that you'd like to add, that's fine. If not, we can move on to the next topic.
Thank you, Chair Peters. It's a really interesting question, but I don't have a number or a hard answer for that. But I do think it's an interesting question, and happy to continue to provide Medicaid-related information as you all work through some of these really global health systems questions that you're addressing in the interim. So thank you.
Chair Peters, may I ask one more question before we leave this topic?
Yes, if we can do it briefly, please.
Yeah, real quick, and you won't be able to answer this, but when you give us all this information afterwards, would you please include, I'm curious on how much we are actually spending per Medicaid recipient. Now we've bumped up the enrollees, we have a significant amount. And I think a simple number would be, what did we spend this year, actually spend per Medicaid patient, not how many we have enrolled versus what we spent per Medicaid patient in the last couple of years. If you could add that data to it, that'd be great. Thank you.
Will do. Thank you.
Thank you. Well, seeing no other questions, hold on, I'm opening up my gallery view real quick to make sure I'm not missing anybody. All right, I think we are ready to move on to the next agenda item, which I believe is agenda item 9. Our presentation on the changes to the Medicaid Managed Care Organization contracts. Under this agenda item, we will hear a total of 5 presentations. The first presentation is from Ms. Rubelid. I apologize if I said that incorrectly. I tried to get some coaching from my staff with Nevada Medicaid, followed by a presentation from each of the 4 MCOs in Nevada. You will hear all the presentations, and then I will open it up for some questions, but only after those presentations so we can make sure everyone gets their adequate amount of time during this piece. Please either take note, send me a quick message if you're interested in asking a question, or raise your hand and hear all those work. Ms. Rubelid, please go ahead.
Thank you. Good afternoon, Chair Peters and members of the committee. I am Sandy Rubelid. I'm a Deputy Administrator for the Division of Healthcare Financing and Policy. I have oversight responsibility for the Managed Care and Quality Assurance Department. I also have with me Teresa Karsten. She's a chief with the division, and she oversees the Managed Care and Quality Unit in case we have any detailed questions that I can't address. Next slide. Okay, so Suzanne touched a little bit on this in her last presentation, but the managed care delivery model differs from the fee-for-service model in that they are risk-based contracts. We do pay a per member per month capitation rate, which is required to be actuarially sound. Mandatory enrollment is in urban, Clark, and Washoe counties. Disenrollment may occur for individuals in unique situations, and tribal members have the option to opt out. Managed care organizations help members navigate the healthcare system. They must maintain an adequate network of healthcare providers, and they have the flexibility to offer additional value-added services. So examples of value-added services would be supportive housing, Costco memberships, free cell phones, things of that nature. Next slide. And so here are our current 4 managed care organizations. We have Anthem Health Plan of Nevada, Silver Summit Health Plan, and as of January 1, we have Molina Healthcare, and they will also be presenting to you after this presentation. Next slide. Excuse me. So here are some services that are carved out of managed care. So what that means is these services are provided on a fee-for-service basis to those members while they remain in managed care. And so I won't read that whole list, so we save some time here. Next slide. Okay, so We did re-procure the managed care contracts, and so we just finished that. The new contract started January 1. Our approach to that procurement was that we contracted with Mercer Government Health Services Consulting to assist us. We also did conduct 8 community listening sessions, and some key decisions that were key facts that we put into the decision to award up to 4 contracts were the ability to expand and have additional choice for members, a minimum number of covered lives threshold for a new vendor to sustainably operate, and then the administrative burden on providers and state staff for oversight. Next slide. So our implementation approach. So we had to onboard a new plan with 3 existing returning plans. So we did have to do system testing with our fiscal agent, Gainwell Technologies, to make sure that the data could flow between the new plan and our fiscal agent. We had a robust communication campaign to providers and members, which is still continuing. We did undergo an external quality review, readiness review, which is required by CMS before allowing Molina to go live. And we do have a command center still ongoing to triage transfer of care issues. The best laid plans always have potential issues. And so we do meet twice a day at the beginning of the day and the end of the day to make sure we can timely address any problems with transition of care. And so the contract did require an equal distribution of members among the plans. So all 4 plans, we distributed 25% per plan. In order to reduce recipient disruption and create market stability, we also offered all members, whether they were redistributed to another plan or not, the ability to switch plans. We did make exceptions for members that were considered high risk, and so examples of that were members that were currently receiving dialysis or chemotherapy, members receiving high-risk case management, which would include high-risk pregnant members, and members receiving value-added benefit of housing services or on a waiting list to receive housing services. And then we do have continuity of care requirement for members. Next slide. Okay, so contract improvements. So these are some of the things that are different from the former contracts that we are implementing with the new contracts. So there are changes to maternal and child health, criminal justice involved, behavioral health systems, both adult and children, health equity, and then there is a new community reinvestment requirement. Next slide. Okay, so in the area of maternal and child health, we do have performance-based auto assignment algorithms, which are focused on outcomes starting in 2023. And so what that means is if a member doesn't choose and falls into the auto assignment, it will be weighted based on contractor performance and the maternal and child health outcomes with a preference given to the higher performing contractors. We do have obstetric centers, freestanding birthing centers added as an essential community provider. We have pay for performance incentives, which are adjusted annually, and we have home visiting encouraged as a value added benefit. Next slide. Excuse me. So for the criminal justice involvement, we have a corrections liaison to facilitate Medicaid enrollment and transitions from prison as the data is available. We do have some timing issues with the data, getting it as currently as we could. So we do have to identify a housing lead to assist individuals exiting the criminal justice system. We also ensure care coordination and case management connections are available for healthcare services and community resources. Next slide. So the behavioral health system enhancements. So residential treatment centers are newly covered by the health plans. They used to be fee-for-service. So that includes case management and discharge planning requirements. The same goes for certified community behavioral health centers, provided they provide an integrated approach for substance use disorders. We have directed payments established to ensure that payment methods are maintained for certain providers, University Medical Center, University of Nevada, Reno, and certified community behavioral health centers. It's a long sentence there. Crisis stabilization centers are designated as essential community providers, and public mobile crisis teams are also designated as essential community providers. Next slide. Okay, so children's behavioral health system has been broadened. State and county children's programs added as essential community providers. Access to treatment providers and services for 12 months is required for children leaving custody, regardless if in network of the plan that they are entered into. So if they are switched from fee-for-service to managed care, they are allowed access to their treatment provider. Ensures enrollment of more essential community providers who treat children, and there's an additional focus on early and periodic screening, diagnostic, and treatment services, known as EPSDT. Next slide. Health equity inclusion. So when available, provider photos are provided. Stratify reporting by racial and ethnic groups, including key health equity metrics and contracts. Facilitate contract language changes to deliver culturally sensitive evidence-based care and reduce health disparities. We require a population health strategy which addresses health equity, and we require participation in a statewide project to reduce African-American morbidity and mortality. Next slide. So community reinvestment, we're really excited about this as a new requirement for our contracts. We require the plans to reinvest 3% back into the communities to support population health strategies. And so part of that implementation is that we require their plans. They are due to the state in March of this year. And additionally, Senate Bill 309 established a reinvestment advisory committee to advise on the reinvestment of funds by managed care organizations. So we're in the process of establishing that committee to be in compliance with that requirement. And next slide. So continued improvement efforts. So Senate Bill 379 established a requirement for healthcare workforce data collection through license renewal. So we're hopeful that future data collection will allow Medicaid to strengthen time and distance network adequacy standards in the future. And then we are also participating in the 988 implementation in coordination with the Division of Public and Behavioral Health for emergent crisis behavioral health needs. Next slide. And I think we're going to hold questions until after the managed care plans present. And then the next slide is just our contact information for myself and Teresa, in addition to a link to the managed care contracts, which are available on our website in case you're interested in any of the details.
Thank you, Ms. Rubalad. We really appreciate that information. I know there are a couple questions that have already come up about the MCO and your particular area, but we will wait until after the MCOs have the opportunity to present to ask those questions. So hang tight, folks. All right. Now our first managed care organization presenting today will be from Anthem, Nevada Medicaid, Blue Cross Blue Shield. We have Lisa Bogart and Lisa Thompson here to present on behalf of Anthem. Do not see them popping up here. Oh, there's Lisa Bogart. Go ahead, please.
Thank you. Good afternoon. For the record, this is Lisa Bogart, Health Plan President for Anthem, Nevada. Presenting with me today is Dr. Lisa Thompson. She's one of our esteemed Anthem medical directors. Thank you, Chair Peters, for the opportunity to present to the committee today. Next slide, please. So it really is an honor for me to serve as a senior leader for Anthem Blue Cross and Blue Shield for over 12 years. Especially given that Anthem Blue Cross and Blue Shield is one of the most recognized brands in the United States. 1 in 8 Americans actually hold a Blue Cross and Blue Shield member card. That's over 117 million people, and that includes about 10.4 million people in 25 states who are Anthem Medicaid members. Anthem's 87 years of experience across the country, extensive visibility, robust membership, deep community support, as well as a broad range of services, not only makes it a recognized brand, but also one of the most trusted brands in providing medical coverage for all stages of life and various life needs. Next slide, please. So I'm incredibly proud that we've been able to bring Anthem's history, experience, and resources to the great state of Nevada. In fact, Anthem has been serving Nevada for more than 50 years, and we have been a trusted partner with their state for over 12 years. We have more than 427 Nevadans that receive services. That includes our commercial, government-sponsored specialty health plans. So that's 1 in every 5 Nevadans. At Anthem, we know Nevada. We have been in Nevada for so long and serving so many Nevadans that we've become experts at really evolving programs, services, value-added benefits, and offerings to effectively really align with our state priorities and to address a broad range of Nevada life needs. We also have more than 1,300 Nevadans that are employed by Anthem, and that's inclusive of our call center here locally in Las Vegas. And we were also the first Nevada health plan to be accredited by NCQA and to be awarded the Multicultural Healthcare Distinction by NCQA, which certainly vouches for our experience in serving diverse populations. We offer service plans for many life needs. That includes Medicaid, Medicare, employer-sponsored insurances, federal employee coverage, specialty vision and dental, and of course the ACA exchange plans. We also invest tens of millions of dollars each year to address state and community needs, whether they be the health, social, or other life needs. So basically, if Nevada has a need, we work for a solution, which is why we've really enjoyed such a collaborative relationship with our state partner over the years and why we look forward to doing a lot more in our aligned mission. So now I'm going to turn the presentation over to Dr. Lisa Thompson to share how Anthem really has evolved to execute on state priorities and our aligned mission. Dr. Thompson?
Thank you, Lisa. Good afternoon, everyone. For the record, I am Dr. Lisa Thompson. As Lisa pointed out, we serve all Nevadans and we meet them wherever they are in their healthcare journey. Anthem's vision is to improve the health of humanity. How do we do that? Through our population health strategy. I know population health is a buzz phrase that's been thrown around a lot lately, but for us at Anthem, it's not just a trendy term, it's what we do. The needs of Nevadans have changed over time and our population health strategy has evolved to meet those needs. This is an area where our innovation really shines. We've progressed from doing retrospective reviews of population data to a fast-forward transformation of best-in-class data analytics that allows us to proactively identify individuals and communities who experience barriers and disparities which prevent them from achieving optimal health. We're guided by a person-centered focus, and our priorities are aligned with those of the state, especially when it comes to addressing quality measures and impacting disparities in maternal and child health, the challenges faced by those living with chronic disease, the social factors that have such a tremendous impact on health, and connecting people with vital behavioral health resources. At the very core of our population health strategy and everything we do is our mission to remove barriers and eliminate disparities so that we can achieve health equity. We believe that health equity is everyone's business, and our work goes well beyond just analyzing data. We established the Health Equity Task Force with every area of the health plan represented. The Health Equity Task Force is a perfect mix of the strength of the tools and resources Anthem has to offer, the passion and dedication of our talented Nevada team, and the deeply rooted trusting relationships we've built in the community through our years of serving Nevadans. The task force is laser focused on empowering people to live the healthiest lives possible. Next slide, please. There are just so many amazing examples of how we've put our mission into action. One of the most recent, of which we are very proud, was a community health event we held in October called the Mammorama Extravaganza. This event was born out of the fact that we know mortality from breast cancer disproportionately affects Black women in Nevada, and especially those living in certain zip codes where there's limited access to resources. So we used our population health model, and together with our Health Equity Task Force, we rolled up our sleeves and we went to work. We partnered with the Nevada Health Centers to bring their mammovan into an underserved community. Through collaboration with many of our community partners, we were able to provide more than 30 mammograms in one day, distribute 250 food boxes, provide flu shots and COVID vaccine, and most of all, engage people in what was a super fun event. Next slide, please. Our doula program is another example of how Anthem has taken the lead on addressing health equity issues in Nevada. This unique program was designed as a direct response to Nevada's poor outcomes in women and children's health and our drive to eliminate disparities. We partnered with the Reno Doula Project and launched the first pilot program for Nevada Medicaid members in January of 2021. By the time the Nevada Assembly Bill 256 passed, calling for Medicaid coverage of doula services, Anthem was already set to expand its program. To date, 100% of the births in this program have been healthy. Next slide, please. Anthem's COVID-19 response highlights our innovation, agility, and commitment to achieving health equity. Since the beginning of the pandemic, we have not taken a backseat or a one-size-fits-all approach. We have consistently taken the initiative to find out what the community needs and what we can do to help. This also means we haven't just focused on Anthem members. We've stepped up to the plate to provide care to anyone who needs it. We've been engaged in a multi-pronged strategy to support Nevadans throughout the pandemic, including digital marketing and social media campaigns to educate communities, connect people to resources, and improve access to care. Our team has worked tirelessly to get over 120,000 COVID vaccinations administered and 135,000 COVID tests done by hosting more than 1,500 events since 2020. It is mind-blowing to realize this included 855 events in Clark County and 285 events in Washoe in 2021 alone. And we're not stopping and we're not slowing down. Back to you, Lisa.
Thanks, Dr. Thompson. For the record, this is Lisa Bogard. So in addition to the programs that Dr. Thompson just shared, I'd like to share another way that Anthem is supporting Nevada, and that's really particularly some of the most vulnerable Nevadas, and that's through our housing support. Anthem firmly believes that housing is health. We believe that housing saves lives. And we believe it so strongly that we've taken some of the boldest efforts amongst the managed care organizations to develop an incredibly comprehensive strategy for addressing the state's housing crisis. Anthem was here when the ACA expansion entered managed care, with many homeless members going straight to the ER for their medical care. We quickly created a mobile crisis assessment team that not only assessed the members, but additionally ensured that they had an appropriate level of care to actually be discharged to. And that discharge plan included access to ensure that they were assessed for additional needs, and that included housing. So we also created the Anthem Pathway Forward program that offers medical, housing, and social determinants of health support to parolees transitioning back into the community. I'm incredibly proud of this program. Since 2018, our program has achieved a very low 5% recidivism rate. So it's a strategy really that has gone into our housing response. It's hard to describe it to you in 10 minutes, but I'd like to highlight just a few things that we've done in regards to our innovative programs. We've been able to divert people from being homeless. We've been able to partner with county and community-based organizations to provide permanent supportive housing, enable identification of housing options when people are homeless, and we assist members really to get back on their feet during the housing, when housing is identified, so that they can really sustain long-term housing stability. So one of the things that we have learned over time is that one size certainly does not fit all when it comes to addressing housing. And that's why we really have to take these situations and listen and assess the situations and come up with those solutions that are based specifically on those members' unique needs. So I have one example that I'd like to share with you. And that is a 54-year-old Anthem Medicaid member who was homeless for 16 years. Since 2019, that member had 353 ER visits and 44 inpatient visits. Several of the admissions were due to psychosis and actually suicide ideations. So one of our absolutely amazing behavioral health case managers was able to connect and get close to this member and really earn his trust. So she found out that really he didn't intend to hurt himself, but he really was just looking for a housing, stability, a place to rest his head, to get some sleep, and to get out of the, sometimes harsh Nevada weather. He was also not adhering to his medication treatment. And so he did have opportunity for other housing, but was evicted for not complying with housing rules, or his psychosis didn't really suit him to be in the room, sharing a room with other men. So our behavioral health care manager, she was able to connect with him. And even though he had been offered injectable medication previously, because of the trust that they had built together, he agreed to take the injections. And actually, after he began them, he said, okay, it's not so bad. This really helped the member stabilize. And because of this, that was really a catalyst for our case manager to help him secure independent housing and a variety of other support services. So the best part about this is that not only the member was able to reunite with his family and begin building those relationships, but he has not had another ER visit or hospital admission since being placed in housing. So this is just one example, but Anthem has recorded, approximately a $2 million reduction in medical costs and ER costs amongst members, and that's within 90 days of being placed in housing. So housing is health, and it really does save lives. Next slide, please.
Lisa, I think this is your last slide. We are at
Yes.
15 minutes approximately, so we'll wrap it up now.
Okay, will do. So one of my favorite things is that member story, and we have so many to share. But really, when I think of the success, it really is the passion of our members, or our associates. They are member focused, they are collaborative, they're agile and results orientated. And that's really what it takes to work at Anthem Blue Cross and Blue Shield. We're fortunate to have a great parent company. We're well resourced and backed by our corporate parent company as one of the world's leaders in managed care. But it really does come down to our true success coming from a local plan that is led and run by Nevadans who love our state and our communities. So we design programs and support with local needs and priorities in mind. And we certainly contribute thousands of volunteer hours to the community and invest millions of dollars each year to support our members in our communities. We provide and support our members and communities in ways that we would support our own families and neighbors. That's because that's who we are supporting, our families and neighbors in Nevada, and we only want what is truly best for our own. So we're proud of what we've accomplished so far and really look forward to continuing our work in alignment with this committee, our state partners, and Nevadans. Thank you very much for the opportunity, Chair Peters.
Thank you so much for being here, both Ms. Bogart and Dr. Thompson. We really appreciate you taking the opportunity to let us know how things are going and the programs that you guys have been building in the state of Nevada. These are some really impressive statistics. Okay, next we're going to move on, and I don't know if folks can tell from our agenda, but we put the MCOs on our list in alphabetical order with no preference. So next would be Health Plans of Nevada, Medicaid United Healthcare Services, and we have Kelly Simonson, who's the president of that MCO, here for the presentation. Ms. Simonson, please go ahead.